All right. Good morning, everybody. I hope your studying is going well. Can everybody hear me, right?
Yeah, buddy.
Yes.
Perfect. Okay, so I hope everybody's studying is going well. We're going to go over the last lecture today, so lecture 9. And I'm going to highlight the key and important things that I feel like is going to be the highest of yields. Of course, like I said last time, Dr. Muffley didn't teach the leg lecture, nor did he teach the foot last year. So I'm basing it just based off like what I think was going to be high yield based on how Dr. Muffley tests and what he emphasized in class yesterday. So my notes are going to correspond to that. And then don't worry, I'm going to post the notes like right after the 9 a.m. session. So right when we finish, I'm going to make sure so I can post those notes for you all so you can use them and study them so you don't have to wait until like the afternoon after the 5 p.m. So I want to make sure you guys get those ahead of time. So after the session, I'll post them. Feel free to study them as much as you'd like. And I'll make sure that you guys are going to be as ready as possible for that exam tomorrow. Are there any questions in regards to anything before I start? Any anatomy, practice exam questions? Actually, wait, we might want to hold off on the practice exam because some people haven't taken it, so I don't want to like answer some questions. I'll answer questions on that at the end. But other than that, is there any other questions?
I just have. Oh, go ahead.
Go ahead.
Okay. I just have a general question when the exam starts. So you are on Canvas, and at 2:00, do you like click the exam? Like, I don't want to be late to whatever I have to click at 2:00.
Yeah. So what I would do, I would just go to like so if it was anatomy, I would go to like the quizzes or something, yeah, and then the exam 1 will click on it, and then you click on exam 1, and it won't it says locked until 2 p.m. And then once it hits 2 p.m., a little button comes up, and then you just click on the button right when it hits 2 p.m. You can like refresh and wait until 2 p.m. But right when it hits 2 p.m., I would just refresh, click, and then just you'll be on your way.
Do you have to do all of those like checks on Proctorio before 2 p.m.? So you basically have done all the checks and then waiting for the exam start button to appear?
You have to do the checks after you put the start button. So right when you click on the start button, that's when you start the checks. But don't worry, the checks won't take too long.
Okay, my other question was about the anterior posterior cruciate ligament. He talked about a couple injuries yesterday, the terrible triad tears, and then one of them was the drawer test to determine like which one was broken. Do we have to know those? Like, are those high yield? Because they weren't on the slides and he only mentioned them.
Yeah. So he only mentioned them. So when we get to ACL and like MCL and stuff like that, I'll talk about them just to make it as clear, just in case he wants to put it on the exam. But I'll make sure to talk about it just to make sure you guys are like ready, and just in case he doesn't like hit you with like something coming from left field. So I want to make sure everything's clear because he does like to talk about or test on what he says. So I will touch on that.
Thank you.
Yep.
Hey, I have a question about the exam. So you know how we're not allowed to use paper? So are we allowed to talk during the exam? Are we going to get disqualified? Like, because if it would just be me, just like talking about myself.
Yeah. I don't think you would be. I mean, if you're probably like yelling or screaming, you would. I mean, I've taken exams and like dogs were barking and stuff like that, and like Proctorio didn't do anything. So like, I mean, if you want to talk a little bit, I would say I think it's okay, but I wouldn't like go like talking like this, like like blah 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 blah, like maybe kind of like a whisper, you know, type of thing.
Okay, thank you.
Yeah.
Would it be okay if a fire alarm went off during the exam? Because my apartment building is apparently going to be doing some fire extinguisher, fire alarm tests and inspections.
I'm not sure.
I emailed you and Dr. Muffley about this, actually.
Yeah, I saw your email and I was like, I think Dr. Muffley should answer that one because I'm not too sure, honestly, because I mean that fire alarms are pretty loud, so and it might be a little distracting for you. I would email Rose. Have you emailed Rose?
No, I haven't emailed Rose yet.
That's the one. That's the person I would email in regards to Proctorio stuff.
Okay, and her email is? Sorry.
No, you're good. I think it's rkim2@ufl.edu. Let me double check.
Yeah, that's it. rkim number 2@usf.edu.
Got it. Yeah. Okay. Thanks.
Thank you.
Justin, with the exam that you posted, the practice exam, is that like a good in like representation of what our exam is, or like what it would be, or would it have like a lot more like clinical questions? You know what I mean?
Yeah, I mean, I feel like the exam is pretty indicative. I mean, he'll probably throw in a few like scenario questions in there. I didn't put some questions in there like on purpose because like I know if I do put a question on there, he'll most likely take it out of the exam. So like for example, like when we talked about like Trendelenburg gate, like I didn't want to put a question on that because I was like, well, if I put one, he's gonna take it out of the exam. And like for example, like you know how I've been talking about like knowing all the cutaneous innervations of the hand. That's another question I didn't want to put in there because I'm like, oh, if I put one in like that, he's gonna take it out of the exam. Such like so like think like I was putting things in there that like that would like help you for the exam as well, but not too much that it's going to be to the point that he'll take it out of the exam because it's kind of like an exact question. You know what I mean? So I feel like it's pretty indicative. I feel like the difficulty was there, and I feel like the way of thinking was definitely along the lines of his exams as well.
All right, thank you.
Yep. Anybody else? Oh, the Trendelenburg gate. Yeah, so on my last lecture, basically what happened for the Trendelenburg gate, basically what it is that it's contralateral diagnosis, which means that if someone has a left hip drop, so like your left like hip is dropping, that means that you have weak right abductors, so on the right side, so abductors, which would be like the gluteus medius and the gluteus minimus. Because what's happening is they're not putting tension on your pelvis, and if they're not putting tension on your pelvis, you're basically hip dropping to the left because your right side is weak. So that's why it's called like a contralateral diagnosis. Okay, and then doing the extra questions. I think I put like 54 questions in there. So yeah, just to give you guys a couple extra questions for that. Any other questions before I share my screen?
Oh, I have one question. For like the professor's exams, are they going to be kind of like in order of how we learned it, or is it just going to be random?
No, I think it'll be random. The order I put it was in the order you learned it, but I think it'd be like more so a little bit random.
Okay, thank you.
Yep. Okay. All right, I'm going to share my screen with you all. Oh yeah, and I added a bunch of slides, so feel free to like take notes, and I mean, yeah, you guys know how it goes, so I'll go through this. What's going on here? Oh no. That's weird. Yeah, I know. No, don't. I know it's a lot of slides, but it's not. It's gonna go by hopefully decently fast. Because a lot of the slides, I'm just gonna be like ba 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 ba, like stuff that won't be like super high yield. I don't know why it's sharing like that. Hold on, 1 second. Oh, and a lot of slides are questions too, like questions and then answers. So like, let's see. Hold on a second. It's saying, I don't know why it's saying that. Okay. Hold on, give me 1 second. Let me see what's going on here. Okay, can everybody see the screen now?
Yeah, we
Yeah.
can.
Okay, all right, perfect. That was really weird. I don't know why I was sharing like that. Okay, this is much better. Can we minimize this? Open up the chat because I can't see anything. Okay. Okay, so yeah, so it's a lot of slides, but it's a lot of it's just gonna be like I'm gonna go through it fast. A lot of it's questions, and a lot of it's just like you guys know how like I like to organize things is to make sure like it's as like digestible as possible. So I'm gonna go through the lecture and then feel free to ask questions. I have questions in between because I wanted to throw in extra questions in there for y'all that I wasn't able to put on the practice exam because I saw like I went to his lecture after and then I was like, okay, let me add a few questions in the PowerPoint as well just to help you all out in regards to what I feel like was going to be the highest of yield. All right. Okay, cool. So this lecture, so we're going to talk about the leg, which is going to basically be anything that's going to be below the knee and above the ankle. So from the knee to the ankle would be the leg. We talked about the thigh last lecture, which would be anything that would be from the knee to the femur, like to the hip, basically. So we'll talk about the leg. Okay. So you have your tibia and you have your fibula. Remember that your fibula is always lateral. So your fibula is always going to be on your lateral side, whether it's your right leg or your left leg. Your fibula is always going to be on your lateral side, and then your tibia would obviously be on your medial side. He talked about your medial malleolus and your lateral malleolus. Just know that those are going to be the little bumps that are on your ankles. So you know, like your medial malleolus, if you feel your ankle on the inside part, that would be your medial malleolus. If you feel your ankle on the outside part, that would be your lateral part, that would be your lateral malleolus, which are on the tibia and fibula respectively. Okay. We have interosseous borders. We talked about this, remember, in the radius and the ulna. You also have interosseous borders or interosseous membranes, which is basically going to be connecting the two bones, right? That's literally anything. I think that's all on this slide. Okay, so for this slide, again, we talked about the interosseous membrane, but I think what's important to note is that through the superior interosseous hiatus, the anterior tibial artery is going to go through that. So again, you're going to have, I'll show you later on, but you have the femoral artery turns into the popliteal artery. The popliteal artery is then going to give off the anterior and posterior tibial artery. The anterior tibial artery is going to go right through here, through the superior interosseous hiatus, and it's going to come right in front of the interosseous membrane. Right? And then the posterior tibial artery is going to stay back, so it's going to stay posterior, and it's going to give out the fibular artery, which we'll talk about as we move on. Okay, so the lateral malleolus is on the fibula, true or false? Or just put A or B, yeah. Okay, and yes, it is going to be true. Yep, so lateral malleolus is on the fibula. We talked about that. The fibula is on the lateral side, so you have the lateral malleolus, and then the tibia is on the medial side, so you have the medial malleolus. Right. Okay, so for arterial supplies in the leg, so I broke this up into arteries and nerves, so you can understand which ones are giving which branches, because when you get into the leg, a lot of things sound the same because it's hard to tell which one's going to be the artery and which one do the nerve because they branch off into like things that are kind of similar. So I broke it up in the following slides. So you'll see, so this is going to be one of the slides about arteries. So basically what he talked about in that paragraph is what we've talked about before, right? That the external iliac artery, right, is going to turn into the femoral artery, right? Femoral artery is going to turn into the popliteal artery, which is right here. This is the popliteal artery. Once it goes through the adductor hiatus, and then it's going to branch into the anterior and posterior tibial artery. Remember, the anterior tibial artery is going to go through the superior interosseous hiatus, which is like right here. It's going to stay right in front. And then the posterior tibial artery will stay on the posterior side. Important to note that the posterior tibial artery is going to branch off the fibular artery, right? So the posterior tibial artery will give off this fibular artery, also called peroneal artery. So same thing, fibular and peroneal. And then you're going to have the anterior tibial artery is eventually going to turn into the dorsalis pedis artery, which is right here. Right, so on the front side, so basically when your anterior tibial artery goes down your tibia, and it passes the extensor retinaculum, it's basically going to turn or be called something else, and it's called the dorsalis pedis artery. You can actually feel the pulse of that if you like try to feel like the superior part of your foot, the dorsal part, right? And you hold it, you might be able to feel the pulse that's coming from your dorsalis pedis artery, which used to be your anterior tibial artery, or like was just a continuation. Also important to note that the posterior tibial artery is going to give the medial and lateral plantar arteries. So again, just to get this straight, so we have femoral artery, well, external iliac artery, giving femoral artery, right? Femoral artery is then going to turn into the popliteal artery, right when it goes through that adductor hiatus, right? And then the popliteal artery is going to branch off into two. It's going to give the anterior tibial artery as well as the posterior tibial artery. Anterior tibial artery goes right through that like superior interosseous hiatus, and then eventually once it goes down into the foot, it turns into the dorsalis pedis artery, right? While the posterior tibial artery is going to give off the fibular artery, and then as it goes down, the posterior tibial artery is going to turn into the medial and lateral plantar arteries, which is right here. So you see the posterior tibial artery just coming down. It already gave off the fibular artery, but it's still coming down, and it turns into the medial and lateral plantar arteries. So that's in regards to the arteries. So which artery gives off the fibular artery? Is it anterior tibial artery, posterior tibial artery, medial or lateral plantar artery?
Hey, Justin, just while people are answering, is he more likely to write fibular or is he more likely to write perineal?
I feel like he used them interchangeably. I mean, he can write either or. I would just note that both fibular and perineal are exactly the same thing.
Okay.
Yeah.
Hey, Justin. I also so when you're talking about the medial and lateral plantar arteries, they're not branching off the fibular artery, correct?
No.
Okay,
No.
So they're separate branches off of the tibial?
Yeah, so this is the posterior tibial artery, but like way higher up, it gave off that fibular artery branch, like right here. So this is the posterior tibial artery, and it gives off this fibular artery branch, right?
Okay.
But then it keeps going down, and then you see it coming down and turning into medial and lateral.
Okay, that makes sense.
Gotcha.
Thank you.
Yeah, this is why I wanted to include these pictures in there, because I started to realize like a lot of these things branch off, and like the nerves branch off into things that sound similar as well, like medial and plantar nerves. So this is why like I wanted to break it up into arteries and nerves before like we started. Okay, and yes, it's going to be B. So again, it's posterior tibial artery, right? So you have femoral artery turning into popliteal artery, right? Right when it goes through the adductor hiatus. Then the popliteal artery branches off into the anterior and posterior tibial artery. Anterior tibial artery going to go through that superior interosseous hiatus, right? And then right when it gets into the foot, it turns into the dorsalis pedis artery. And then you have the posterior tibial artery just branching, or giving a branch of the fibular artery, also known as the perineal artery. And then as the posterior tibial artery keeps going down and down and down, once it gets into the foot, it turns into medial and lateral plantar arteries, just like that. Nice. Okay. Again, here's the breakup of the leg. So here's the artery supply, or the arterial supply. So the anterior leg is going to be the anterior tibial artery. That makes sense, right? So we talked about this going to the anterior side. That's going to take most of the anterior leg. The deep posterior leg muscles, which are going to be these muscles right here. These are going to be the deep ones, right? Because this is like anterior. This is going to be lateral. This is going to be deep posterior. And this is going to be superficial posterior, right? So this deep posterior is going to be posterior tibial artery. That makes sense because remember, like we said, that the anterior tibial artery goes through that interosseous hiatus. Well, the posterior tibial artery just stays behind and stays almost directly attached. Well, not attached, but right behind the interosseous membrane. So it would make sense that it supplies mostly all the deep posterior leg muscles, right, which are closest to the interosseous membrane right here. The superficial posterior leg muscles is going to get the fibular artery. Remember, that was the branch off the posterior tibial. And then you're going to have right here, which is the lateral, is going to get branches off this fibular artery. So we'll go through that as we move on, but I wanted to give you all a quick summary in regards to what the arterial supplies are going to do. Okay, and then here are nerves. So for the nerves, I gave you all another slide for nerves right here so that we understand what's going to be the breakup of the nerves. So I put the boxes like in yellow to make it seem like it's nerves. So you have your sciatic nerve, right? So your sciatic nerve is going to turn into your tibial and common fibular nerve. So here's your sciatic nerve, right? It keeps going down, 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 and then it splits up into your tibial, which would be right here, tibial, and then your common fibular nerve, right? So your tibial nerve, if it keeps going down, once it gets all the way down to the foot, it turns into the medial and lateral plantar nerve, right? This is why I wanted to give you the nerves, because the medial and lateral plantar nerve come off the tibial nerve, but the medial and lateral plantar arteries are coming off the posterior tibial artery, right? So it kind of it's a little confusing, but that's why I wanted to make slides on it, because you want to understand the differences between the nerves and the arteries, even though they sound the same. And then you have common fibular nerve, which is right here. Common fibular nerve gives you your superficial as well as your deep fibular nerve. Your deep fibular nerve is just going to supply your anterior leg muscles, and your superficial is going to just take your lateral. We'll get into that as we move on, but this is just an overview. I'm gonna pound this in to make sure you guys really understand this, but this is just the general overview of the arteries and nerves. So all of these are arranged correctly, except sciatic nerve going into tibial and common fibular nerve, tibial nerve going into medial and lateral plantar nerves, common fibular nerve going into superficial and deep fibular nerves, or none of the above. All right. So it is going to be, yes, D. And the reason why I put this in there is because I wanted you all to use this as a study slide. So now that you know, this is the exact order of the branches. So it's sciatic nerve giving off tibial and common fibular nerve, like we see. So sciatic nerve giving off tibial and common fibular nerve. Tibial nerve, when tibial nerve keeps going down and down and down all the way into the foot, it's then going to give medial, right here, medial and lateral plantar nerve, right? So here's our tibial nerve coming down, giving off medial and lateral plantar nerve. Excuse me. And then you have common fibular nerve giving the superficial and deep fibular nerves. So common fibular giving superficial and deep. So I put this question in there to help you all study. So remember, everything in this on this question is correct. So it will be able to help you in regards to what the branches are for the nerves in regards to the leg, as well as in the foot. All right. So yeah, good job. Yes.
Justin, I have a quick question.
Yeah.
I think I don't understand the question. That's the problem. So it says all of these are arranged correctly, except. So what are we supposed to find exactly? I just don't understand the exact question.
Yeah. So the question was basically so for example, if I put sciatic nerve gives superficial and deep fibular nerves, that would be wrong, right? Because obviously it's not direct branches. That's what the question was asking. But obviously I put it in order to make sure it was for study material. So that's why I wanted to make sure you all had a slide in regards to what exactly was branching off of what.
Okay, thank you.
Yeah, of course. All right. And then here are the nerves. So these are going to be the nerves. The anterior leg is going to get the deep fibular, also perineal nerve. So that's just going to be this nerve right here going all the way to the front side. Is going to be your deep fibular nerve, right? So the deep fibular nerve is just coming to the front, and it's going to be supplying your anterior leg muscles. Your lateral leg muscles, which are going to be lateral leg muscles, are going to be getting superficial fibular nerve, right? Also known as perineal nerve. So coming over here, superficial perineal nerve, just taking the lateral muscles. And then your posterior leg is going to be getting your tibial nerve. So that's going to be the general overview. I know it seemed like a lot in the beginning, but I wanted to give you a general overview of the arteries and nerves before we started getting into these muscles. And then we'll reinforce the nerves and arteries as well as we go on. Okay, so again, so here's his slide. So we talked about this already. Remember, femoral artery coming down, turning into the popliteal artery. Popliteal artery giving off this anterior tibial artery, right? So it's going to go towards the front side of the interosseous membrane, anterior tibial artery. If it continues down into the foot, it's going, or it does. Once it continues down to the foot, it's going to turn into the dorsalis pedis artery, right? This posterior tibial artery, it's okay, I'm going to give a branch of this fibular artery. So it gives a branch of the fibular artery, also known as the perineal artery. And then there's the posterior tibial artery. Once it goes all the way down to the back of the foot, it's going to turn into the medial and lateral plantar arteries, right? So This is why I wanted to talk about this is why I wanted to talk about it in the beginning so that we understand these branches. And that's going to be that in regards to this slide. Nothing too important here other than the fact, great saphenous vein is going to drain into the femoral vein. And then we have our small saphenous vein draining into our popliteal vein. But the small saphenous vein drains into the popliteal vein, but then popliteal vein is then going to go up into the femoral vein, right? So it's the same thing with arteries in regards to nerves. Like, they have the same names. They're just going backwards because they're bringing blood to the heart, right? So that's going to be that. So I think that's the most important thing to note here. Okay, so this is going to be a TBT question. So what is the lateral superior border of the popliteal fossa? So what is going to be the lateral and then superior? Is it going to be biceps femoris, semimembranosus, or lateral or medial head of gastrocnemius? So lateral superior. All right, I'll give you one more second. Okay. So yes, it is going to be A, biceps femoris. So yeah, biceps femoris, very good job, is going to be the lateral superior border. Yes, the medial superior border will be the semimembranosus and semitendinosus. And then you have the medial inferior border is going to be the medial head of the gastrocnemius. And then the lateral inferior border will be the lateral head of the gastrocnemius. So yes, very good job on that one. Here's our lumbosacral plexus again. I'm not going to talk about it too much because we talked about it a lot last lecture, but I put this slide in there again in order to help you study. These are going to be the branches like we've talked about before. I'm not going to talk too much about them because we've talked about them already, so I'm going to skip this slide, but this is going to be for your notes. And then again, these are going to be the borders of the popliteal fossa. This is the one I just questioned you guys on. I wanted to make sure you knew it before we talked about it. Again, you have your lateral superior border, which is going to be your biceps femoris, so lateral and superior. Then you have your superior and medial. That's going to be semitendinosus and semimembranosus. And then you have your inferior, medial, and lateral borders will be the heads of the gastrocnemius, respectively, right? And then here will be its contents. So yes. Okay, so before we talk about the popliteal artery, I wanted to put this image in there in order for us to understand what the branches are of this artery, because he puts cadaveric images on there. And I wanted you to understand like where these arteries are coming from and what these branches are. So I feel like this picture does us a lot of justice in regards to what the popliteal artery gives off. So just to give you an overview, like the femoral artery is over here coming down, right? And then turning into the popliteal artery. Excuse me. So it turns into the popliteal artery, and then it's going to give off these four branches, right? So you have superior lateral right here, superior medial genicular arteries, right? The reason why they're called superior is because they're above these, because you have inferior ones, and they're called genicular arteries because that's like the arteries that are anastomoses around the knee, right? So this would be superior lateral and superior medial. You also have your inferior lateral, and you have your inferior medial. Right, so I wanted to give you this quick overview of this image just to show you what we're pointing out when we talk about these cadaveric images, right? So these are the popliteal artery branches, right? Okay, so I edited this slide just a little bit because I feel like it wasn't too clear to look at it. So I took a screenshot basically of Ackland's tape, and I wanted to like really point out what he was talking about. So the first artery he talked about was going to be the superior lateral and superior medial genicular arteries. Remember this slide that we talked about, right? This is our femoral artery turning into our popliteal artery, right? Popliteal artery gives off our superior lateral, superior medial, inferior lateral, and inferior medial. Okay, so the best way to look at this image when it comes to like cadaveric images is like, okay, I see this is the image that he gave, and this is like the screenshot I took. I mean, you could tell, right? So this is like the screenshot I took. Basically, the best way to look at this is use the gastrocnemius as your landmark. And what I mean by that is that these two heads right here, so right here, and right here, use those to your advantage. Like that is the gastrocnemius. So if he's pointing at arteries that are above that, they have to be the superior ones, right? Because the inferior ones are going to be below the gastrocnemius, right? So these two heads of the gastrocnemius, if he's pointing at this one or that one, you know those are going to be the superior ones, right? So this one is going to be the medial, which is the same thing he points over here, medial. And this one's going to be the lateral, which is going to be right here, the lateral. So again, use the gastrocnemius to your advantage, because the gastrocnemius is going to be like right here, like covering the inferiors basically. And here we are pointing at the superior lateral and the superior medial, right? So superior lateral and superior medial. Remember, this is the popliteal artery, right? So this is your popliteal artery giving off your superior lateral and superior medial. Yep. So I hope this like picture makes a little bit more sense, because I feel like this one was, I couldn't see the arteries too well. So I screenshotted it right here. So this is the superior lateral and superior medial, right? So use the gastrocnemius as your landmark. Okay, and then the next slide is going to be the inferior one. So here's the inferior.
Hey, Justin, I have a question.
Yeah.
Will the lateral always be higher than the medial?
That's a good question. In the pictures that he's going to post, I think so, because he's just going to use the same ones that are from Ackland, and on Ackland they show him to be lateral, show him to be higher. So I guess it's assumed that it's going to be higher. Yeah.
Okay, cool.
He's not going to pull another picture out from another leg that he's never shown. You know what I mean? So yeah, if that's going to help you remember it, then go ahead. Okay, so this is going to be the inferior lateral and medial genicular arteries, right? So again, use the gastrocnemius as your landmark. Here's your gastrocnemius right here. And you see the branches are like basically within the gastrocnemius. Then I'm like, okay, I can like knock off all the superiors, right? It can't be a superior because it's within the gastrocnemius, or kind of like below the gastrocnemius, right? So use that to your advantage. Then from there on, it's just a 50-50 chance, because you already know now it's going to be either medial or lateral, right? So you have medial right here, medial inferior genicular artery, and you have inferior lateral genicular artery. So this is going to be the lateral, right? So this is going to be the lateral, and then this is going to be the medial inferior genicular artery. Okay, so medial inferior genicular artery, and then lateral inferior genicular artery. And again, use these gastrocnemius to your advantage. Is this image the medial side? Is this image, the medial is higher than the lateral? Oh yeah, but this, in regards to the inferior ones, yeah, it looks like it is, yeah. So that's why I don't want you guys to get too confused in regards to like, oh, this one's on top of that one. What this is that this is going to be the right leg, or right like thigh and leg. So this is why this is like the medial side, because it's going towards the right side of your right leg, and this is going to be the lateral side, so it's going to be the lateral side of your left leg. It's the same thing in this image, right? This is going to be your right leg, so this is going to be the medial going to the inside of your right leg, and it's going to be the lateral going towards the outside of your right leg. How will we be able to tell it's right or left? Well, over here, so I mean, when you look at these cadaveric images a little bit more, you can tell that these are going to be like the semimembranosus and semitendinosus over here, right? So this is going to be on the lateral side. And the gastrocnemius, I mean, obviously they're going to be bilateral, so it's going to be hard to tell which one is which. But I will use this like as like your take in regards to what's going to be on the lateral and what's going to be on the medial. Right. Oh yeah, you can also use your pes anserinus as well, which would be over here. Yeah.
Is
so you can,
the other way that the semitendinosus and semimembranosus are on the medial side?
So wait, what'd you say?
The semimembranosus and semitendinosus are on the medial, and the biceps femoris is lateral.
Yes. You're right. Semitendinosus and semimembranosus is going to be on the medial side, and then the biceps femoris is going to be on the lateral side. Yes, because this is most likely going to be coming from the iliotibial tract, coming from the tensor fasciae lata. This is most likely going to be the biceps femoris. So yes, you're right. Use your pes anserinus, which is going to have the three muscles that are going to be attaching towards the medial side. Yep. All right, and when you look at the image more often, like you'll be able to understand, and I put questions in here as well in order to help you get a grasp of which one is which. Right. Okay. So we talked about the inferior ones, which would be right here. We talked about the lateral inferior genicular artery, and we also talked about the inferior medial genicular arteries. Use this image. This is like the picture perfect image in order to help you understand what the branches are. Okay. And then here's the slide that he put, but we talked about this, right? These are going to be the superior ones because you use the gastrocnemius to your advantage. This is superior medial. This is superior lateral, right? Here's the gastrocnemius again. Okay, you know that it's below it. So this is going to be, we have lateral right here, right? And then we have medial over here, right? So if you use the gastrocnemius to your marker, you'll be able to tell which ones are superior and which ones are inferior, right? So that's going to be those in regards to the branches.
Medial.
What happened?
What's that one above the medial?
Oh, this one right here?
Uh-huh.
That's just a branch. That's just like a small branch that's supplying the gastrocnemius. It's not important.
Okay.
Yeah. Okay. Any other questions that I missed? Okay. Cool. All right, and then so you have your sciatic nerve, and it's branching in the popliteal fossa, right? This is why, like, I talked about the nerves and arteries before, because I didn't want to jump into this without us getting a good grasp of it, right? So we have our sciatic nerve coming down the posterior side of your thigh and leg. I'm splitting into your tibial nerve and your common fibular nerve, also known as your common peroneal nerve, right? So that'll be right here. This is tibial nerve. This is common peroneal nerve. So I wrote that right here as well. All right, so here's to put your knowledge to the test. So which structure is indicated by the white arrow? This white arrow right there. Okay, I'll give you a few more seconds. All right. And yes, it is going to be C. So yeah, you all answered that pretty quickly, right? So you use the gastrocnemius to your advantage. We can knock out A and B, right? And now we're in between C and D. And if we know, remember that the medial is going to be this branch. You can't see the lateral. It's kind of just like coming straight across, but you'll be able to see the lateral in another picture. But this is, yes, going to indeed be the medial, the inferior medial genicular artery. And again, I put this note in here, use the gastrocnemius as your landmark. So yes, very good job. Okay. So we're going to talk about the leg, right? And then we'll talk about the different compartments, which would be the anterior, which is also known as the extensor. Remember, the anterior compartment in the leg is going to be called the extensor. And it's going to be the extensor compartment. I know it's a little weird to think about anterior as extensor. Yeah, I can show the gastrocnemius. So this is going to be the gastrocnemius. This is one head, and this is going to be the other head. So these are the gastrocnemius right here. Okay. And then, yeah, so it's important to realize that the anterior compartment of the leg is going to be the extensors. That's the one that brings your toes up, basically. So it allows for dorsiflexion, right? That's going to be, I know it's a lot of things that sound opposite to each other, but dorsiflexion is the same thing as extension, and that's going to be from the anterior compartment. We also have the lateral compartment, and then we'll talk about the posterior, deep, and superficial. Okay, so he puts the arteries and nerves in here, but look, we've talked about these before already, so we should understand generally what the branches are and what the nerves are going to be. We talked about them earlier in the lecture, but I broke it up into a slide like this. Excuse me. So you have our anterior leg, right? So that's going to be anything that's going to be in the front side of your leg, right? So like where your front leg, like where your shins are, right? That's your anterior leg, right? That's going to be supplied by the anterior tibial artery. Okay, good. That's easy to understand that the anterior tibial artery takes the anterior leg. The deep fibular or deep peroneal artery, deep fibular or deep peroneal nerve is going to supply the anterior leg, right? So here we are right here. The common fibular nerve is giving off this deep fibular nerve. This one right here, this deep one. This is going to the front side of the leg, right? So it's going to the front side of the leg, and it's going to be supplying the anterior leg. So the deep fibular nerve supplies the anterior leg, right? So for the lateral leg, it's going to be the superficial fibular nerve, right? So the superficial fibular nerve is basically going to the side of your leg, and it's just taking the lateral muscles of your leg, right? So you can see it right here. This is your superficial fibular nerve just branching off and taking the lateral side of your leg, right? And then you also have for the lateral leg in regards to arterial supply, it's going to be the branches off the fibular artery. So here's your perineal artery, right? Or your fibular artery. Branches off of that is just going to take some of the lateral leg. Deep posterior leg, which is going to be anything that's very close to the interosseous membrane, but on the posterior side, right? Which makes sense. It's going to take posterior tibial artery because we said, remember, posterior tibial artery just stays like right on the back side of the interosseous membrane, which is why it supplies the deep posterior muscles, right? And then we also have tibial nerve. Tibial nerve is going to take the entire posterior leg. You're going to have the deep posterior leg as well as the superficial posterior leg will be bitibial nerve. And in regards to the arterial supply, it's going to be fibular artery for the superficial posterior leg. I know this is a little bit a lot, or this is a lot at once, but again, this is why I keep wanting to reiterate it from the beginning, from slide 1, and we'll keep going over it and we'll keep reinforcing it as we go throughout the lecture. All right, here's going to be our anterior compartment right here. This is our lateral compartment. This is going to be your deep posterior, and this is going to be your superficial posterior, right? It's going to be that, and we don't have to worry about the one on, we don't have to worry about the one on the right. Okay, so which artery turns into the dorsalis pedis artery? You might have saw it, but which artery is going to turn into the dorsalis pedis artery? Is it going to be A, B, C, or D? Dorsalis pedis. The thing about a dorsalis is on the top part of your foot, and then it's going to basically be the pedis, which is foot artery, and it's going to be, give you one more second. All right, so yes, it's going to be the anterior tibial artery, right? So the anterior tibial artery is eventually going to turn into your dorsalis pedis artery, which is going to be right here. Right, your anterior tibial artery coming straight down, turning into your dorsalis pedis artery. Right, your posterior tibial artery is going to come down and split into your medial and lateral plantar arteries. But it's also going to give off the fibular artery much higher up. Right, so those are going to be the splits in regards to the arteries. Okay, so he talks about the muscles, and there's a lot of them, I know, but this is why I split them up into their individual compartments. So I'll talk about the anterior, the lateral, the posterior superficial, and the posterior deep in regards to their own compartments, right? So I'm going to use those, and then I'll split them up accordingly, right? So let's get right into it. Okay, so, so I just put like one slide in there just to remind you what dorsiflexion and plantar flexion is. Dorsiflexion is going to be bringing the foot up, right? So bringing the foot up is going to be dorsiflexion. So toes up is going to be dorsiflexion. Toes downward is going to be plantar flexion, right? So dorsiflexion up, plantar flexion down. So we have our anterior compartments. So I split them up into our anterior compartment first. We have our extensors, which is also known as dorsiflexion, right? So dorsiflexion is going to be bringing your toes up, right? That's dorsiflexion. So we have our tibialis anterior, our extensor digitorum longus, our extensor hallucis longus, and our fibularis tertius, or can I pronounce that? Tertius, yeah. So remember that these are going to be supplied by the deep fibular nerve, right? So these are going to be supplied by the deep fibular nerve. Remember, the deep fibular nerve or deep perineal nerve is going to come off the common fibular nerve, right? Which is going to obviously come off the sciatic, right? So, and it's going to supply, and we also have our anterior tibial artery supplying the anterior compartment, right? Because remember, our anterior tibial artery just coming right through that superior interosseous hiatus, and it's staying towards the anterior side of the interosseous membrane, which is why the anterior tibial artery takes all of our anterior leg, right? So that's going to be the two supplies in regards to those. And this is like an easier image to see, right? So here's our common perineal, and this is our deep fibular or deep perineal. You see how it's coming to the front side or like the anterior side? This is why the deep perineal or the deep fibular is going to take the anterior leg, you can see the superficial perineal stays more lateral, which is why when we talk about the lateral compartment, that's going to be supplied by the superficial perineal nerve, right? So I feel like this image does us a little bit more justice in regards to where these nerves are going to. So here's our tibialis anterior. He didn't put a single cadaveric image of the tibialis anterior. I looked for it in this lecture. I didn't see any. So the only one I have is going to be this picture, which is going to be obviously like a cartoon picture of it, but it's going to help us realize what the tibialis anterior does and what it's going to, and where it's going to be positioned, right? So the tibialis anterior, again, we have our deep fibular nerve. Remember, deep fibular nerve coming off the common fibular nerve, that's taking the anterior leg, that's taking all the anterior leg. And we also have anterior tibial artery. And again, based on how this is shaped, right, coming from the condyle of the tibia all the way towards the medial side of this first metatarsal, you don't have to like know the exact like spot, but just know it's going to be going all the way down here. And what's important about that is that the tibialis anterior is going to help with dorsiflexion, right? So imagine like when I say pulling, right, this tibialis anterior is pulling the foot upwards, right? So when it contracts, it's pulling the foot upwards, meaning toes up, meaning dorsiflexion, right? It's dorsiflexion of the foot at the ankle joint. It also has some slight inversion. The reason why that makes sense is because if we understand the attachment of the tibialis anterior, which is on the medial side right here, just underneath, like right here under the first metacarpal, if you pull, like you said, or you contract the tibialis anterior, so this is pulling back, right? You can tell that it's going to lift this foot kind of like this way, right? It's kind of going to invert your foot. You know how like you roll your ankle, like most of the most common way to roll your ankle is like inverting it. So if you roll your ankle that way, that's what the tibialis anterior helps a little bit with because of its attachment, right? This is why it's important to understand their attachment because yes, of course, it helps with dorsiflexion because it's pulling the foot upwards, but it's also going to slightly help with inversion, right? Because of the way it's positioned or the way it attaches to distally, right? So this picture is going to give us a little justice on that. Okay, and then when I put all these other slides, I have like the cadaveric image according to it next to it as well, so that you can like study like on one slide because he put like the extensor digitorum longus on like slide like 60 or something like that. So I just grabbed it and like put it on this slide. So like I like to put the cartoon one as well as the cadaveric image next to it as well. Can I explain inversion and eversion? Yeah. So when you roll your ankle, for example, 99% of the time when you roll your ankle, imagine like putting pressure on the lateral side of your foot, right? So like it's like when you like this is your ankle, right? And you just like kind of like this is your right ankle and you kind of just roll on it like that. That's inversion. Eversion is like the opposite way, the turning the foot inwards. It's really hard to evert your foot, honestly, because we don't have that many muscles that evert your foot. So it's actually very hard to evert it, which is why you rarely like sprain your ankle everting. Inverting is going to be like this. Basically, this is like your right foot and it's kind of like turning outwards, right? So like kind of like, oh, like I rolled on my right ankle, like outwards. Does that make sense? All right. So we have the extensor digitorum longus, right? So this is going to be the extensor digitorum longus, and it's going to be located right here on the tibia, and it's going to be attaching. When you say helping with inversion, is it participating in inversion or it's participating in it? Yeah, it's participating in the inversion. Obviously, its main function is going to be dorsiflexion. That's the main function of the tibialis anterior. That's like the highest yield to know. But just know that like it has some slight inversion. So when he talks about which muscles do some inversion, he'll add a few in there. And I just wanted to explain why he added a few of those ahead of time. Okay, so extensor digitorum longus. So this is going to be going, as you can see, it goes all the way to the distal ends of all your toes except for your thumb. Right. So if you match this cartoon image with this one right here, you can see that this is the extensor digitorum longus, right? This right here, because you can see the tendons, these 4 tendons going all the way to the distal ends of the foot, right? So this would be the extensor digitorum longus. Right? Remember, all the extensors on the anterior compartment. It's going to be supplied by deep fibular nerve, again, and as well as anterior tibial artery. And obviously helps with dorsiflexion, right? So that's extensor digitorum longus. Next one is going to be the extensor hallucis longus. So extensor hallucis longus is going to be obviously in the anterior compartment as well. Because remember, extensor, same thing as dorsiflexion. It's going to bring the toes upward. Hallucis, meaning it's going to the thumb, or excuse me, the big toe. Right, so it's going to be going to the big toe. And longus. This is it right here, right? Because you can see this tendon right here, right? This tendon is going all the way to the toe and only the toe. So that's how you can tell that this is on the anterior side, so it's extensor. It's going to be a tendon that's going all the way to the toe, and it's originating from the leg. This is going to be the extensor hallucis longus, right? Again, deep fibular nerve, which comes off the common fibular nerve, and the anterior tibial artery. And again, it's going to help with dorsiflexion of the big toe, right? So bringing the big toe upwards. That's going to be extensor hallucis longus. The last one that's going to be part of the anterior compartment is going to be the fibularis tertius, right? Also known as the perineal tertius, right? So I also put the cadaveric image in here as well. So you have your, again, deep fibular nerve, an anterior tibial artery. Here's your fibularis, or also known as perineus tertius. So this is it right here, this little thing, right? So this is going to be the fibularis tertius. It's going to be exactly this muscle right here, right? So you can see how the cartoon image looks exactly like the cadaveric image, right? This is going to be the perineus tertius, also known as the fibularis tertius. And it's going to help with dorsiflexion at the ankle joint, and it helps with some slight eversion, right? Obviously, because it's attached to the lateral side, so if it contracts, it's going to evert your foot, so turn your foot basically inwards, right? But it's very, very slight. Like I just put that in there just because it's on the lateral side. So highest thing to know, or the highest yield to know, is that it dorsiflexes at the ankle joint, right? So that's going to be the perineus tertius. Why is the image showing plantar flexion? Oh, it's just showing you the image just to show you the muscles clearly. There's no reason why it's plantar flex. It's just showing you just to show you how the muscles look like. No, but when it contracts, it's going to do dorsiflexion. I just put this image in there because it's easy to see all three of the muscles at once. You can like disregard how the foot looks.
I have a quick question.
Yeah.
So for all of these muscles, do we need to know like the exact attachments? Like for example, like for the thigh and stuff like that, we needed to know like exactly where they proximally attach and distally attached. Do we need to know the same for this ones?
Yeah, so he said in lecture yesterday that he wanted you to know like the attachments for the legs. So for anything that's originating from the leg. So I would know the general attachment. I mean, I wouldn't know that like, for example, like this goes all the way to like the fifth metacarpal or the fifth metatarsal, excuse me. I would know that it's going to like the lateral side of the foot, right? Even though it's an anterior compartment muscle, right? And then we talked about like extensor hallucis longus. If you know the names of the muscles, you know exactly where they're going. Like this one's going all the way to the big toe, right? So extensor hallucis longus. So a lot of the names have it in and of themselves, like exactly where they go.
Okay, so we need to know like generally like where they're located. Like for example, if they're like towards like the tibia or like the fibula, but like we don't need to know exactly like where in that bone it's going to attach to.
Yeah, I would say I would say it's a little low yield for that, but I would still know exactly like where it goes generally, like big toe, toes 2 to 5, lateral side, medial side, etc.
Okay, gotcha. Thank you.
Yep.
Yeah, correct me if I'm wrong, Justin, but he didn't have a whole lot of origin or insertions in this entire PowerPoint, right?
Yeah, so that's why I'm like, I don't think it's super high yield to know exactly the origin and insertion, but if you know like where it's located, like, okay, it's on the lateral side of the tibia and goes to the lateral side of the foot, then you know what it does, and I think that should be suffice, right? Because you do need to know where they come from, because if you just memorize muscles and not know where they exactly are, if he throws a cadaveric image in there, you're not going to know which muscle it is. You know what I'm saying?
Yeah.
But I wouldn't say go memorize it's the second or third metatarsal. Do you see what I'm saying? I would just know generally where they are.
Okay, cool. Thanks, man.
Yep. That's why I didn't put like the attachment specifically on here. Yeah, he said he might have a bone picture. I'm guessing he's going to point at something and ask. Yeah, I guess for a bone picture, he'll probably ask, I don't know. I told you he's never put pictures last year, but for bone pictures, he might just put like a femur and be like, is this a femur or a humerus or like a radius or tibia? Yeah, that might be one of the bone questions he would ask. I would say that that would be a fair one that he can ask, would be like one of the bones. Like highest yields would definitely be like fibula, tibia, femur, and humerus. Actually, all the limbs, obviously. So I would just know like all the limbs, just know what they look like generally. But we've talked about them a lot, so it should be able to help you out a little bit. I think he maybe talked about. Yeah, I mean, he didn't talk about the attachments too much. Which of the following muscles do not attach to this? Pointing at the greater trochanter. Yeah, I mean, he could do that as well. It's a little bit more difficult question. but he could definitely put a question like that as well. Okay. And again, that was our anterior leg, right? So this is going to be the anterior leg. This is the summary of the 4 muscles that we talked about, the anterior leg. Tibialis anterior, which goes obviously towards the medial side. You have your extensor digitorum longus, so going towards toes 2 through 5, helping with dorsiflexion. We have our extensor hallucis longus, which is going all the way to our big toe and helping with dorsiflexion. And then you have your fibularis tertius, which is going towards the lateral side, helping with dorsiflexion and some slight eversion. So which anterior leg muscle dorsiflexes the big toe? Is it A, B, C, or D?
I have a side question
Yeah.
about like all the grades. Obviously, we can't discuss any grade. We don't have any grades yet. But if you're borderline, I'm guessing it's a do not email me kind of topic, and they don't curve at the end. Is that correct?
Yeah, that's correct. Yeah, they don't curve at all. Yeah, if they do curve, it's just going to be on an exam. Like if like there's a really low average, they might curve, but they won't just curve because you emailed them. They'll just curve because the average is too low in regards to each exam. But that's about it.
And they would tell us that if that happened?
Yeah, you would know. Yeah, they'll like send an email or something saying that they curved the exam, but don't ask them for a curve because they're not going to do it.
Oh no, I wouldn't ask. Okay, thank you.
Oh no, I know. Okay, so which anterior leg muscle dorsiflexes the big toe? So yeah, yep, extensor hallucis longus. Yes, really good job. Again, that's going to be, extension is the same thing as dorsiflexion, right? So that's going to be the extensor hallucis longus going all the way to the big toe and just helping with extension, excuse me. Okay, so we talked about the anterior compartment, and now we're going to talk about the lateral compartment, right? So the lateral compartment is going to be obviously on the lateral side, and that's going to get the superficial fibular nerve, right? And how does that make sense? Because we have our common perineal nerve right here, giving off our deep perineal nerve as well as superficial perineal nerve. We talked about the deep perineal nerve. Remember, that's going to take the anterior leg. Our superficial perineal nerve, which is right here, is just coming along and taking the lateral side of the leg. Oh yeah, and I put a picture here. Here's your inversion and eversion. So here's inversion. This is inversion, where the pale leg is right here. This is the pale. This is inversion. And then the blue one is going to be eversion, right? You see how eversion is very hard to do? Like try doing that with your foot. It's obviously really hard to evert your foot. Much easier to invert it, right? So much easier to invert your foot. So this is the image right here in order to help you the difference between eversion and inversion. Oh, the reason why I put that is because the lateral compartment helps with eversion. This is why I put a star here. But it's only 2 muscles, which is why we can't evert that much. And we have ligaments, obviously, that prevent us from everting a lot as well. Okay, so we have fibularis longus as well as fibularis brevis. Remember, it's the same thing as peroneus longus as well as peroneus brevis, right? So here's our fibularis longus. So here we are again. We have our image as well as the cadaveric one that he put in the slides. So fibularis longus, remember, this is going to be this muscle right here, right? It's on the lateral side of the leg. It's pretty long. It attaches almost all the way to the top side of the fibula, right? So you can see this fibularis longus all the way up here, right? So that makes it a little bit easier to identify, right? It's all the way towards the top. That's the fibularis longus, also known as the peroneus longus. Superficial fibular nerve, as well as branches of the fibular artery. What's important is like you see this fibularis longus, and it's going to be attaching right here, right? So the lateral side of the foot, right? So if you contract this fibularis longus or this peroneus longus, it's going to evert the foot, right? So it's going to turn the foot inwards, right? It's going to evert it like this because it's going to pull it and it's going to turn it like how the blue foot looks, right? It's going to be the fibularis longus or the peroneus longus right there, right? It's important for us to note that the fibularis tertius is on the anterior compartment, right? So it sounds like the other 3 muscles, but this is part of the anterior leg. So it's important to note that the fibularis tertius is part of the anterior leg, while the other ones, fibularis longus and brevis, are part of the lateral leg, right? And then here's our fibularis or peroneus brevis. Here it is right here, slightly smaller, right? So this is going to be right here, slightly smaller. You can see it looks exactly like this cartoon image, right? So it's kind of like, I mean, not exactly, obviously, but you can see how it originates like this. They've removed the peroneus longus, right? Because you can't see it because you'd be attaching all the way up here. So this is your fibularis brevis, right? So you have superficial fibular nerve, and it's going to evert the foot, right? So it's going to evert. Remember, it's going to be turning your foot inwards, right? And you also have the branches of the fibular artery. So those are going to be your two lateral compartment everters. As you can see, we don't have many muscles that help with everting the foot, right? So which muscle is indicated by the arrow? So it's a little test your knowledge. Is it the peroneus longus, peroneus brevis, peroneus tertius, or the extensor digitorum longus? Damn, y'all look quick. No, I'll give you a few more seconds. Okay. So, yes, it is going to be the peroneus tertius, right? So the peroneus tertius, also known as the fibularis tertius. Yes, this is part of the anterior compartment. And the ones that we just talked about were the fibularis longus and the fibularis brevis, which are going to be part of the lateral compartment, right? This is going to be part of the anterior compartment. And those are going to be that. Yes, so very good job on that one. Okay. And then for the posterior compartment, so we broke them up into flexors, which are going to be plantar flexion. You have superficial and deep. Remember, plantar flexion is bringing the toes downward. So when you bring your toes downward, that's going to be plantar flexion, right? So you have superficial and you also have deep, right? So we'll talk about the superficial first, and then we'll get into the deep ones after, right? So superficial first, and we'll talk about the deep. So just important to note that the tibial nerve is taking all of these, basically. The tibial nerve is taking the superficial as well as the deep posterior compartment leg muscles. Right, so it'll be the tibial nerve, but the superficial gets the fibular artery, while the deep gets the posterior tibial artery, which makes sense because remember the posterior tibial artery is like staying close to that interosseous membrane on the posterior side, which makes sense as to why it gets the deep posterior muscles, right? So this would be the deep posterior muscles right here, and then this would be the superficial posterior muscles, right? So we'll talk about the superficial ones first, just so that we don't have to like go through like all 7 of these at once. So we have our superficial posterior compartment muscles first. So we have our gastrocnemius, our soleus, as well as our plantaris, right? This is going to be our gastrocnemius. We have our soleus, which is right here. You can't see it too well, but if you remove the gastrocnemius, you'll be able to see the soleus. And our plantaris, which is located right here. We'll have better images of that once we break up the slides individually, right? So important to note that the gastrocnemius as well as the soleus are going to attach to the Achilles tendon, which is also known as the calcaneal tendon, right? So that'll be right here. This calcaneal tendon is going to be where the gastrocnemius as well as the soleus attaches to. Right, so the gastrocnemius and soleus both attach to your Achilles tendon, also known as your calcaneal tendon. And again, this is taking tibial nerve. Tibial nerve is taking the posterior compartment, and this is going to be supplied by fibular artery. So we'll break these up into the individual muscles. So again, we're talking about the superficial posterior compartment, right? So superficial posterior compartment is going to be obviously on the posterior side, most superficial. Oh yeah, and if you need me to slow down, please let me know. It's hard to know how fast I'm talking because I'm only talking to a screen, so let me know if I'm talking too fast. Okay, so for gastrocnemius, right, this is going to be it right here. Here's our corresponding cadaveric image, right? This is our gastrocnemius right here with its 2 heads. This is going to be its cartoon picture-perfect image. As you can see, it inserts into the Achilles tendon, which is then going to go to the calcaneus, which is your heel bone, right? So it's going to be supplied by your fibular artery as well as your tibial nerve. It's a 2-joint muscle. The reason why it's a 2-joint muscle is because your gastrocnemius is going to cross your knee joint, right? And it's also going to cross your ankle joint, right? So it's going to flex the leg at the knee, right? And it's also going to help with plantar flexion at the ankle joint, right? So if you get on your tippy toes, right, you'll feel your gastrocnemius, so basically your biggest calf muscle, right? You get on your tippy toes, that's plantar flexion, right? So that's going to engage your gastrocnemius, right? So getting on your tippy toes is going to be plantar flexion, your gastrocnemius, and almost all of your posterior compartment leg muscles are going to be engaged when you're on your toes, right? And it's also going to help with flexion at the knee joint, right? The reason why it helps that flexion at the knee joint is because it crosses the knee joint, right? Since it crosses the knee joint, it's going to assist with movements of the knee, and that will be flexion, which is going to be bringing this, for example, tibia and fibula backwards, basically. So bringing it back. Right? So bringing this posterior. That's going to be flexion. All right. Next one is going to be the soleus. So here's our soleus right here. You see it's still attaching to the Achilles tendon right here, just as large, but they've removed the gastrocnemius, right? So they removed the gastrocnemius, and here's our soleus, right? Here's our soleus right here again, and this is going to be the cadaveric image. You can see it's attaching to this calcaneal tendon, also known as the Achilles tendon. They removed the gastrocnemius, right? So it's going to be supplied by the fibular artery as well as the tibial nerve. And again, plantar flexes the foot. Again, if you stand on your tippy toes, that is plantar flexion, and you're going to feel it in your calves as well as your soleus, as well as almost anything in your posterior compartment, leg. So that would be soleus, right? Question? Okay, I think somebody's mic went on.
Oh,
okay.
Hey, yeah, sorry, I had a question.
Oh, yeah, you're good.
Really quick, you were saying the soleus is deep to the gastrocnemius?
Yes.
Okay, cool.
And then, do you mind explaining the difference between extension and flexion at the knee? Yeah, okay, so if you're... Okay, let's see what the best way to explain this is. So if you're at the gym, for example, and you're sitting on one of those machines, right, and you're just like one of those leg machines, just sitting on them, and you push your legs upwards, basically. So you're like lifting your legs in order to work out your quads. You know what I'm talking about? Like those machines, you just lift your legs up. That would be extension at the knee, right? Because you're lifting, your knee is going from 90 degrees and it's going to 180 as you bring it up. So when you're working out like your quads, like on those like little machines that you sit on, and you're basically just kind of like putting your legs upwards, that's going to be extension of the leg, right? Because you're working on your quadriceps, which help with extension of the leg as well. When you're flexing it, it's the same thing when you sit on that machine, but when you're pulling your legs back, basically, so when you're pulling your legs backwards to work on your hamstrings, for example, that's going to be flexion at the knee, right? So you're going to be bringing your knee backwards, right? So that's going to be flexion at the knee. So that's flexion and extension at the knee. Does that help a little bit in regards to the extension and flexion? If you want me to clarify a little more, I can as well.
Can you also review extension and flexion of the thigh at the hip?
Yeah, so when you're at, like, for example, let's say you're sitting at the bottom of a squat, right? If you're sitting at the bottom of a squat, when you're going upwards, that's going to be extension at the hip, right? When you're going downwards, that's flexion. So you can see when you're going down for a squat, basically, you feel that your angle between obviously your thigh and your hip is decreasing, so it's going to be flexion at the hip. But when you're coming out of the squat, that's extension of the hip.
Yeah. Okay, sounds good. Thanks, man.
Gotcha. Okay, are the hamstrings flexion at the knee and extension at the hip? The hamstrings are going to be flexion at the knee, and they're going to be, yeah, I think they help with slight extension at the hip. Yeah, but your biggest hip extensor is going to be your gluteus maximus, right? So when you're thinking about hip extension, that's mostly going to be the largest muscle, which is going to be the gluteus maximus. Okay, so that's soleus, right? All right, and then we have plantaris, right? So plantaris, it's going to be like this weird muscle it's kind of like, it looks like this, obviously, and it's just a long tendon going all the way toward your calcaneus, or whatever you want to pronounce it, basically, and it's going to be attaching to your heel bone, basically. So it's this long tendon, super small belly, but long tendon that goes all the way to the calcaneus. Again, it's a two-joint muscle. I mean, obviously, it won't be the highest of yields, but it's obviously a two-joint muscle because it crosses the knee joint as well as the ankle joint, but it's such a small muscle. It flexes the leg at the knee joint, right? So it flexes the leg at the knee joint, and it's also going to weakly plantar flex. The reason why it's weak is because the belly is so small and the tendon is so long, like it's going to help with plantar flexion, but it's very little, right? Because it's such a small muscle. And that's why I put like a weakly plantar flex to the foot. That's going to be plantaris. And again, tibial nerve as well as fibular artery. All right, so what is the innervation of the extensor hallucis longus? So extensor hallucis longus, which one of these is going to be the innervation? I want to test your knowledge. Okay. Give you a few more seconds, of course. Okay, so it is going to be, yes, B, the deep fibular nerve, right? So we talked about this already. I talked about it since the first slide. I want to keep reiterating it, that the deep fibular nerve gets the anterior leg muscles, right? The superficial fibular nerve gets the lateral leg muscles, right? So our two lateral leg muscles, the peroneus longus and the peroneus brevis, is going to be supplied by the superficial fibular nerve. Common is obviously just gives off these two branches, and then tibial nerve is going to take the posterior side of the leg, right? So the superficial and deep. So yes, very good job, extensor hallucis longus, which I put the cadaveric image right here. Okay, last one. So last compartment we're going to talk about is going to be the deep. So deep posterior compartment. So we have the popliteus, the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. So here's this corresponding image right here. This is going to be the deep. So we removed our gastrocnemius, we removed our soleus, and we also removed the plantaris, right? So we removed all of these muscles back here, so you won't be able to see, obviously, any of those here. You only see the popliteus, which would be this one, tibialis posterior, flexor digitorum longus, and flexor hallucis longus, right? And again, these are going to be supplied by the tibial nerve as well as the posterior tibial artery. Again, it makes sense because the posterior tibial artery stays very close to the interosseous membrane, which is why it takes the deep posterior compartment muscles, right? So we have the first one that's going to be our popliteus, right? So this is going to be our popliteus. This is going to be the cadaveric image, and this is going to be like the cartoon image of it. The only thing it does is basically it's just going to unlock the knee, basically. So for example, if you're standing straight up for too long and then eventually you just like start walking, I guess, you unlock your knee, your popliteus is just going to help you just like kind of just unlock your knee. That's all you need to know about what it does. It's going to be innervated by the tibial nerve, and it takes the posterior tibial artery. So again, this is the popliteus. This is its corresponding cartoon image. Tibialis posterior. So you can see this is going to be the tibialis posterior. So on the posterior side, it's going to be originating from right here and going all the way towards this side, right? Towards the medial side, but obviously the medial side. Yeah, this is the medial side. That should be suffice. You're going to have the posterior tibial artery supplying that, right, as well as the tibial nerve. It's going to plantar flex the foot at the ankle joint, right? And it's going to have some slight inversion as well, right? Some slight, very, very slight inversion, obviously because if it pulls, it's going to, obviously, it can help you invert your foot, which would be turning it like outwards, basically, so to the side. This is your tibialis posterior right here. So you can see that it looks kind of just like this muscle right here. Right? So this would be your tibialis posterior. And again, he put another picture of it from a different angle, so I put this image in there as well. And this is going to be your tibialis posterior as well. Right? So that's going to help you study in regards to this muscle, tibialis posterior. Okay, and then we have flexor digitorum longus, so it's going to go towards the digitorum, which means just like obviously the fingers or toes 2 through 5, right? So that's going to be a flexor digitorum longus, so it's right here. And you can see it going underneath the foot, right, and going all the way towards the ends of toes 2 through 5, right? Or excuse me, 2 through 5. That's going to be innervated by tibial nerve as well. Remember, flexor digitorum longus is going to help with plantar flexion of the toes 2 through 5, right? So toes 2 through 5 is going to be flexor digitorum longus, right? And this is going to be it right here. This is it. And then we have flexor hallucis longus. This is going to be the last one, I believe, and it's going to be supplied by the posterior tibial artery again, and the tibial nerve. I like to put the arteries and nerves on every slide just to reiterate which ones are going to be supplied by which. And it's going to plantar flex the big toe, right? Because it says hallucis. When you hear hallucis, think big toe. When you think pollicis, or when you hear pollicis, think thumb, right? So I'll be flexor hallucis longus, going all the way towards the end of the big toe. And this is going to be the image right here, flexor hallucis longus. Right? So which muscle is indicated by the structure below? This one right here. Flexor digitorum longus, flexor hallucis longus, tibialis posterior, or popliteus.
So Justin, real quick,
yeah,
in regard to the flexor digitorum longus, I kind of got a question like this in undergrad. Basically, they would put like what flexes the phalanges like 2 through 5, and they would put like flexor digitorum superficialis, profundus, and then they would put the foot muscle digitorum longus as an option. Like, what do you think? You think Muffley would do something like that?
Yeah, he can. I mean, I did that on my. I think I did that on my practice exam for one of the questions.
Oh,
yeah,
okay.
So it gets confusing, but you have to know like the differences. Yeah, he can definitely do that. I think it's definitely possible.
Cool. Thanks, man.
Got you. Yeah. I know it's super savage to do that, but I think that is a question that Muffley could ask. Because they all start sounding the same, which is why you want to make sure you understand which muscles are which. Right? All right. What type of question? Oh, like that he can ask, for example, which one of these flexes phalanges like 2 through 5. He can be like, let's just say of the toes. He's gonna be like, is it flexor digitorum profundus, flexor digitorum superficialis, or flexor digitorum longus? So obviously the first two are for the arm, but you might not know that because they all sound the same, right? Because they're all like flexor digitorum, but you want to make sure that flexor digitorum longus is for the leg, while flexor digitorum superficialis and flexor digitorum profundus is for the arm, or a forearm, excuse me. Yeah. Okay. Yeah. So the answer is going to be yes, A. So it's going to be flexor digitorum longus. Yep. So that's going to do plantar flexion of the toes 2 through 5. Okay, so and then these are all his slides. So I'm gonna breeze through these pretty quickly because I added like 20 slides before to talk about or break them up into their own compartments. So I'm gonna go through these pretty quickly, but this is basically exactly what we talked about in all the previous slides. So again, here's the anterior compartment that he said. Remember, we have our tibialis anterior, extensor digitorum longus, extensor hallucis longus, as well as fibularis or tertius or peroneus tertius. Those are all going to be part of the anterior. We have anterior tibial artery and then deep fibular nerve. It's going to be those. Okay. And then lateral leg, we talked about this. Remember, this is going to be the superficial fibular nerve taking the lateral compartment. That's going to be the fibularis longus as well as the fibularis brevis, right? And they just get branches off the fibular artery, right? So that's going to be the lateral leg. And I'm going to go through this pretty quickly because we've reiterated these on the previous section. Okay. And again, here are the images. So you'll probably see duplicates of these images because I copied and pasted a lot of the images that were throughout the lecture and brought them back to their specific muscles. So you'll see these images multiple times. So it'll help you like reiterate it. Like this is the peroneus longus, right? Because it's going all the way to the end, right? It's pretty long. So it's going all the way to the end. You remove the peroneus longus, you see the peroneus brevis, right? And then you see the peroneus tertius coming towards the front side. It's a little small muscle. Yeah, odds are if you see a small muscle like near the foot, like right here near the ankle, it's going to be the peroneus tertius because it kind of looks very distinct to the other muscles, right? That's the peroneus tertius. And then posterior compartment, we have our superficial, which is the ones that we talked about, which are gastrocnemius, our soleus, as well as our plantaris, right? So those are going to be our superficial ones, right? So again, gastrocnemius and soleus are going to attach to the calcaneal tendon, also known as the Achilles tendon. And then you have your plantaris over here. Tibial nerve, right? Tibial nerve as well as the fibular artery is going to supply the leg. So again, here's your gastrocnemius, right? You can see it with its two heads right here. This is the gastrocnemius. You remove the gastrocnemius. You see the soleus, right? I don't even think he put a picture of the soleus, but this would be the soleus right here, right? This would be the soleus here as well. And then this is going to be the plantaris. And then this would be the popliteus. I'm not sure why he put the popliteus after the superficial. Well, this is why I reorganized there a little bit. But yeah, this is going to be this is odd to put this here. But yeah, this is going to be the popliteus. We talked about this already though. Plantaris and gastrocnemius. Okay, so posterior leg muscles, and this is going to be again the gastrocnemius. I put this picture in the earlier slides. Remove the gastrocnemius, you see the soleus, right? These both attached to the calcaneal tendon, and then you have your plantaris, which is just your long muscle that goes all the way towards your calcaneus, right? And then you have your calcaneal tendon, which is going to be connected to your gastrocnemius as well as your soleus, right? And again, here are deep muscles. Okay, yeah. So again, remember tibial nerve, that's just taking the entire posterior leg, and then posterior tibial artery is taking the deep portion of it, right? So he just highlighted all the muscles that we've talked about before. Our tibialis posterior, right here, our tibialis posterior. Flexor digitorum longus, going all the way to the toes 2 through 5. Flexor hallucis longus, going towards the big toe. And then this is just the flexor retinaculum, right? And again, we talked about these. These are going to be the posterior leg, right? And again, these are just copied and pasted image that I had in the earlier ones, but this is going to be our tibialis posterior, right? So you can tell this is the back side of the leg, and then you can see that this is going to be the tibialis posterior, right? It's easier to see that in regards to when I put the cartoon image. I know it's hard to see it by itself, but when you look at the tibialis posterior slide, you'll see the cartoon image, and then you see the tibialis posterior, and then you can kind of like match it, and then it'll help you like get in your head like what exactly the tibialis posterior looks like and where it should be located. Right. Okay, and then so yep, those are going to be everything in regards to all the muscles in the leg. All of these. So we talked about all the muscles in the anterior, lateral, deep posterior, as well as superficial posterior. Right, so we talked about all of these, and here is a question. So which structure is indicated by the arrow below? Plantaris, soleus, gastrocnemius, or popliteus? So which one of these is indicated by the one below? Okay, I'll give you one more second. Okay. Yes, it is going to be D, the popliteus, right? So your popliteus is just gonna like kind of just like unlock your knee, not crack your knee, obviously, just unlock it. So it's gonna help you unlock your knee when you're just kind of like standing up for a long time and haven't moved, right? So that's your popliteus. So very good. Okay. So again, those were all the muscles that we talked about. Dorsiflexion, remember that's going to be extension. That's going to be on the anterior compartment, right? Our extensor digitorum longus, our extensor hallucis longus, tibialis anterior. These are plantar flexions that we talked about. We've talked about inversion as well. Which ones do some slight inversion? Which ones do some eversion, which we talked about. Eversion is mostly just going to be the lateral muscles, which is the peroneus longus and then the peroneus brevis. So again, this is eversion, and this is going to be inversion, right? So the pale is going to be the inversion, and then you have the blue is going to be the eversion. Okay. So again, so he talked about this anterior compartment syndromes in the leg. So I just put what he put like in this paragraph. I put it on the next slide and summarized it. So here's the anterior compartment syndromes in the leg. I also put a picture associated with it. So what's happening is that we have like oh, okay. So anterior compartment syndromes in the leg. So what happens is that you have like this very tight fascia that's going to be surrounding your anterior leg muscles, right? And what happens is that if you have pressure within that, or if you have compression of the anterior leg muscles, also called the extensors or the dorsiflexors, it can lead to obviously a lot of problems, right? Because it's going to lead to lots of pain, and what's going to happen, and loss of possibly loss of extension and dorsiflexion if you go through tissue necrosis, right? So the treatment for that would be incising or cutting, basically incising the fascia, so you can relieve the tension in the anterior compartment. It's like the same thing that happens in the carpal tunnel syndrome when they cut the flexor retinaculum in order to relieve tension in the median nerve. Same thing here. You just incise the fascia, right? And what's going to happen, like, what happens if you don't treat it, right? If you don't treat this anterior compartment syndrome in the leg, that's going to lead to foot drop. And what is foot drop? The foot drop is basically like if you lift your foot up, right, and then you can't hold it up. Basically, you can't hold your toes up. Basically, your toes are going to keep pointing down. So no matter what, even when you lift your foot, you can't extend your foot, so you can't dorsiflex your foot. That's basically foot drop because your toes are pointing down. It's kind of like your muscles in your anterior compartment are not working, right? So that's what would happen, because if you have tissue necrosis of the anterior leg, your foot is just going to be like this. You won't be able to bring it up, right? So it would lead to foot drop. Limited dorsiflexion and left foot, but the toes are still going to be pointed down. So you can see if you're walking with some anterior compartment leg syndrome, what's going to happen is your foot's going to drag, because when you pick up your foot, your toes are not going to be coming with you. So you're more likely to slip, more likely to drag your toes because your anterior muscles are not working. Your extensors or your dorsiflexions are not aligning to bring your toes up with your foot, right? So that's going to be anterior compartment syndrome. And again, it can also happen with obstruction of the peroneal nerve, but specifically the deep peroneal nerve, right? Because the deep peroneal nerve is going to take the anterior compartment muscles. So if you injure that or if that is affected, that can also lead to foot drop as well, right? So again, here, common fibular nerve. So yeah, if you damage the common fibular nerve, anything that's going to be distal to that is going to be affected, which is obviously the superficial as well as the deep fibular nerve. So injury to the common fibular nerve, paralysis of all the muscles in the anterior and lateral compartments, which makes sense, right? Because the two branches that come off the common fibular nerve is the deep fibular nerve as well as the superficial fibular nerve. If you damage the common fibular nerve, you're damaging both of those things that are coming after. Basically meaning you have no innervation to your anterior compartment as well as your lateral compartment. Meaning you're going to have no dorsiflexion and no eversion. The most important thing clinically is no dorsiflexion, right? Because if you have no dorsiflexion, you're going to lead to foot drop. Your toes are not going to be able to go up. This is why this individual right here is going to be dragging their toes, right? So no extension and dorsiflexion, or no extension, also known as dorsiflexion, and then no eversion, right? So deep fibular nerve, again, is going to take the anterior compartment, and then the superficial fibular nerve is taking the lateral compartment, right? So again, that was basically everything in the leg. We're going to talk about the knee, so we'll go to the knee. Okay, do you guys need like a 2-minute break or anything like that, or do you want me to keep going?
I'm good if you're good.
Okay, yeah, I'm good. Okay, so we have the knee. So we'll be talking about the knee. Again, this is just to reiterate what we talked about. This is the pes anserinus. Remember, SGS. That's the order it goes in. It's going to be sartorius, gracilis, and then semitendinosus. Those are going to be, we talked about this before, so I won't highlight it too much, but these are going to be the muscles that are attached to the pes anserinus. Again, you have your iliotibial tract. This is some notes about the last lecture or the previous lecture that we talked about before, right? That the gluteus maximus as well as the tensor fascia lata are both going to be attaching to the iliotibial tract, right? So our gluteus maximus as well as our tensor fascia lata attached to our iliotibial tract, and this is going to be our biceps femoris, right? Nothing too important to note on this slide. You have your quadriceps femoris tendon, patella tendon, patella ligament. Nothing too important on this slide. Okay, we've talked about this before. There's nothing to highlight in this slide. We talked about gastrocnemius, plantaris, as well as popliteus. Okay, on this slide, we have our medial collateral ligament as well as our lateral collateral ligament, also known as our fibular and tibial ligament, respectively, right? Our tibial and fibular collateral ligament. So the reason why I put attached and space in between is because when you see these cadaveric images, this is going to help you so much in distinguishing the difference between the medial and the lateral collateral ligament, right? That the medial collateral ligament or the medial or tibial collateral ligament is going to be attached to the joint capsule. So when you see it on the cadaveric images, it's going to always be attached to the joint capsule, unless they obviously cut it and then like pull it down or something like that. But it's going to be attached to the joint capsule. Your lateral fibular ligament is going to be having a space in between your joint capsule as well as the ligament in and of itself, which is why I put there's a space in between. when we talk about the ligaments, I'll show you all so it's easier to tell which one's the MCL and which one's going to be the LCL, right? He said not to worry too much about the oblique popliteal ligament.
Can you repeat that one more time? I'm sorry.
No, you're good. So your medial collateral ligament, which is going to be this one, is always going to be attached to your joint capsule, right? So this is your joint capsule, basically. It's going to be attached to that. So when you see it on cadaveric images and he's pointing at something, you'll always be able to tell which one's the medial and which one's the lateral because the medial is always going to be attached to the joint capsule. Your lateral collateral ligament is always going to have a space in between the joint capsule as well as the lateral collateral ligament. It'll make more sense when I point out the images as well. Okay, so here's our anterior cruciate ligament and our posterior cruciate ligament, so our ACL and our MCL. And then we'll talk about the medial and lateral meniscus as well. The reason why it's called ACL is because it attaches from the anterior tibia and then goes posteriorly, and then your PCL is going to attach to your posterior tibia and go anteriorly. We'll talk about that when we get a little bit more in depth in these ligaments. Again, medial and lateral meniscus. I'll talk about this more when we look at the cadaveric images because it'll be easier to explain where these are and what they look like.
Justin,
yes.
What's this TOF P on the side?
TOF P.
TOF P.
Yeah, I honestly don't even know what that is.
Okay.
I don't know what he's saying. Yeah.
I think
tendon of popliteus.
I think he's saying it's T of P, the tendon of one of the muscles.
Popliteus.
Yeah. Okay.
Okay, thank you. I googled that. I literally couldn't find it anywhere.
Yeah, no. Sometimes he likes to shorten things. Like sometimes I don't even know what he's shortening it into. But yeah, I guess that would just be the tendon. Not too important to look at it at this angle because you won't get an image like that in that angle. You know what I mean? All right. Okay, so I enlarged these pictures because they were way too small for my vision. And then I wanted to make sure that you guys could see what exactly is going on here. Okay, so this is what I'm going to get in depth in regards to the anterior cruciate, actually all the ligaments. Right, so I enlarged all the images. We'll start with the lateral and medial meniscus, right? So the way I like to remember the medial meniscus is like the McDonald's, like so M is for medial and the C is for the C-shaped of the medial meniscus. So that's in order to help you that the meniscus, the medial one, looks like a C, right? So whenever I see this in cadaveric images or like in the cadaver lab, it's always going to look like this C structure, right? So McDonald's, so M for medial meniscus and the C for the shape that it looks like, right? Then this is going to be the lateral meniscus, right? It's going to be the lateral and this is going to be the medial meniscus, right? So this will help you remember which one is which in regards to those menisci. And then here's what I'm talking about the tibial and then the fibular collateral ligament. You see how the tibial collateral ligament is attached to the joint capsule, like it's literally like slapped onto the leg or slapped onto the knee? That's the tibial collateral ligament. The fibular, you see how there's a gap in between? Basically, okay. So basically, there's going to be a gap in between the fibular collateral ligament just because it's going to be easier to see that because the fibula is like kind of like to the side of the tibia. That's why there's a gap in between because it goes from the fibula to the femur, right? So obviously there's going to be a little bit of gap in between. So that's the easiest way to tell the difference between fibular collateral ligament and tibial collateral ligament because tibial, that's just attached to the side. Fibular, you'll see this little space located right here. Okay, so for anterior and posterior cruciate ligament, so this is going to be the anterior and this is going to be the posterior. So when he said about like the anterior drawer test, like what he was like, oh, like you can test to see if somebody has an ACL injury by doing the anterior drawer test. So what happens is that if you're just like laying down on your back, right, and you just put your leg up and you put it at like 90 degrees, right, you're just kind of holding your leg up at like your knee at 90 degrees and you're just holding it up, right, and like let's just say like a physician grabs your leg, right, they grab your leg. And basically what's going to happen is they're going to pull it towards them. They're going to pull it towards the physician, basically. So they'll pull it, and if it goes too far, then they know that you're basically going to have an anterior cruciate ligament injury. And then the posterior cruciate ligament, it's the same thing, just the opposite. They're going to push, right? So they'll push, which is why it's called the posterior drawer test. And that'll show that if you have a posterior cruciate ligament, sounds really painful, but that would be the way in order to determine if someone has an ACL tear as well as a PCL tear. So with this one, this is why it it makes sense, that anterior and posterior draw test. So basically, this is the anterior cruciate ligament, right? Going from the anterior tibia to the posterior femur. It's preventing the tibia from displacing forward, right? So this is basically, so it's making sure that the tibia doesn't go forward, right? So imagine like it's keeping your knee in place. So if your tibia goes too far forward, that means your ACL is torn, right? Because this is supposed to prevent this tibia from just going and shooting out of your leg, basically, right? Or shooting towards the front side of your leg. So that's why with the anterior drawer test, they're kind of grabbing your leg, right? And then they're pulling it towards them, which is basically meaning pulling the tibia towards the physician, pulling it towards the person. And if it goes obviously farther than normal, that means you have an ACL tear. That sounds so painful, but yeah, it makes it sound like an ACL tear because it's going to be pulling too far, meaning that your ACL is compromised. It's not doing what it should be. Your posterior collateral ligament, your PCL, does the complete opposite. It makes sure what prevents your tibia from displacing backwards. So it makes sure that your tibia doesn't go back so posteriorly. So basically, you're going to grab the leg, and if you push the leg towards the person, if it goes too far, or if you feel like a mushy kind of feeling, that's when you can indicate 90% of the time they have a PCL injury, right? So you have ACL as well as PCL, right? And that's what they do. That's the purpose of those ligaments, and they're commonly torn. More so ACL.
Hey, Justin?
Yeah.
Do you remember the name? I don't know if you had said it, but the name of the test that Dr. Melfi said they used to test this like kind of motion?
Yeah. So for ACL, it's anterior drawer test. So anterior drawer test, pulling the leg towards the physician. PCL, it's posterior drawer test, which is pushing it towards the patient. You can look up videos on that too. It's pretty cool, honestly, to see how they test that.
All right, thanks.
Okay, got you. Yeah. Okay. So yeah, this is nothing too high yield on this slide. I mean, it's just a bunch of images, but just looking at like some bunches of tears. He talked about the terrible triad, which is just going to be damages to these three ligaments, right? Like the medial meniscus, ACL, and then as well as the medial collateral ligament. Pretty bad, actually really bad if you tear all those, but it's possible. But he talked about it in class. That's just a terrible triad. I think that's the only thing that's going to be of yield in regards to this slide. Okay, and then genicular arteries, we talked about these. Remember, I put this image again in here just to remind you what the branches are. These are going to be the branches of the popliteal artery, right? You have your superior lateral and medial, as well as your inferior lateral and medial, right? Just coming around the knee joint. Okay, so which ligament is this picture pointing to? Is it the tibial collateral ligament, ACL, fibular collateral ligament, or PCL? Question? No. Okay. Okay, give you one more second. So yeah, if you use your helpful tip, you'll be able to tell which ligament this is.
Justin?
Yes.
Can you repeat the triad muscles one more time, please?
Yeah, so so the terrible triad is going to be ACL, MCL, as well as medial meniscus. So MCL, also known as the tibial collateral ligament. Okay, so which ligament is the picture pointing to? Question or no?
Oh, I was just going to say thank you.
Okay, yeah, you're good. Okay, so this is going to be the fibular collateral ligament. Remember, the space in between, right? So you see that there's going to be space in between. This is going to be the fibular collateral ligament, and you can also tell because this is the fibula and this is the tibia, right? So fibular collateral ligament, also known as LCL, which would be your lateral collateral ligament. Yes, very good job. Okay, and then we'll talk about the ankle and foot. And then we'll talk about the supplies in regards to those as well. But we won't go, I don't think, too in depth into these as much as we did with the leg. I'm not going to go over these. Feel free to go over them yourself, just to practice where they are originating. He gave you the answers right there as well. Same thing over here. The only thing I'll touch upon is that he said the order that they pass. Yeah. So the order that they pass the medial malleolus is going to be Tom, Dick, and very nervous Henry. So I mean, he said it, which is why like I put a slide on it the next time just because I wanted to put a slide because he did talk about it, and that's just basically going to be the order from anterior to posterior in regards to how they pass behind the medial malleolus, right? So this is going to be on the inside of your ankle, right? These are going to be the structures. So what he means by that is this. So you have a Tom, Dick, and very, well, it doesn't have the very, but that's just going to be the vein. Very nervous Harry. So basically what it stands for is that you have your tibialis posterior first, which is going to be located right here for Tom. And for Dick, you're going to have flexor digitorum longus, right, to be right here. And an very nervous, which is just artery, vein, and nerve, right? So it's going to be tibial artery, doesn't have tibial vein, but tibial vein and tibial nerve. And then posterior to that, Harry, you're going to have flexor hallucis longus. So, I mean, I just put a slide in it just in case he would test on that. I mean, I feel like it's on the lower aortic side, but I did put it just in case because he did talk about it in class. So I just put a little picture in there just to show you the differences or what he was talking about when he said that acronym. And here are the answers to like this picture that he talked about. Okay, so here's going to be the flexors of the toes. I think he meant to put flexor, which is why I corrected it. So this is going to be the flexor digitorum longus. This is going to be the flexor hallucis longus, and then this is going to be the tibialis posterior. Again, I copied and pasted these images. So again, like he put the tibialis posterior all the way on this slide, but like I grabbed it and I put it all the way in the beginning in regards to right next to the tibialis posterior, so you can study that as well. So these are going to be the flexors of the toes. Okay, and then for this slide, I edited it a little bit because I wanted the digitorum longus and brevis to be next to each other. I don't know. I was just being picky because I feel like you got to put them next to each other. So then I put the extensor hallucis longus next to the extensor hallucis brevis, just to show you that you have an extensor digitorum longus coming from the leg going all the way to the foot, but you also have an extensor digitorum brevis, which is just located in the foot. Right? This would be extensor digitorum brevis. Same thing over here. You have extensor hallucis longus originating from the leg going all the way to the big toe, and you also have an extensor hallucis brevis, which is just basically in the foot and just goes to the big toe. Right, so basically these are corresponding to each other. One originates from the leg and goes to the foot, and the other one is going to just stay in the foot, basically. And that's going to be the extensors of the toes. Nothing too high yield here. He said not to memorize this. Okay, which muscle is indicated by the arrow? So this arrow right here, this muscle right here. I'll give you a little bit of time on this one.
Hey, Justin.
Yeah.
Real quick, the ACL and PCL, is it to prevent the tibia from moving or the knee? Which bone does it prevent from like moving forward and backward?
The tibia.
The tibia? Okay.
Yeah.
Thank you.
No. Okay. Give you one more second. All right. So it's going to be, so yeah, you have to orient yourself. So before I give the answer, so like if the way I would look at this is like, okay, this is the anterior side of the leg, right? Okay, so first of all, this has to be extensors, right? So I can knock out A and C, right? Because these have to be extensors because it's the anterior side of the leg. And then I see this is the foot, right? And then I'm like, okay, so this is going to be the foot. And then this is going to be giving off the 4 branches. So it has to be extensor digitorum longus, right? So when I see, I like look at the muscle and then I see its distal attachment. If I see it's going to like, for example, these 4 toes, then I know it's extensor digitorum longus. If it's only going towards the one big toe, then I know it would be extensor hallucis longus, right? So that's the way I would like look at these cadaveric images in regards to studying them for the exam. So yes, that would be extensor digitorum longus. Okay. Ankle and foot, we talked about these already. Dorsiflexion, plantar flexion, inversion, eversion. Let's see, the most important thing I would note is that the calcaneus is just going to form your heel, right? So your calcaneus is basically your heel. And above that, you have your talus, right? So this talus is going to articulate with your tibia, right? So the talus is going to just articulate with your tibia, so talus with your tibia, so T for T. And then you're also going to have your navicular and cuboid. I would just note that your navicular is medial and your cuboid is lateral. I think that's what I would note from that your navicular is going to be mostly medial, like medial superior, and then your cuboid is mostly going to be lateral. Right, and then here's your cuneiforms, medial, intermediate, and lateral, which attach to these metatarsals, right? And then these would just be phalanges. Okay. Nothing high yield here, just transverse tarsal joint as well as the tarsal metatarsal joint. They say exactly what they do from the tarsals, and this would be from the tarsals to the metatarsals, right? I mean, he glimpsed over the ligaments a lot, so I mean, I'm not going to talk about them too much. He did go through them pretty quickly, so I would just look at them. I mean, they do say where they go to. So, for example, tibia to fibula, talus to fibula. Like they basically say exactly where they go to. So, I think that would just be it. MCL, which would be called the deltoid ligament. Your question?
Hi, Justin. Yeah, on the last two slides, those are all the tarsal bones, correct?
Yeah, so these are all the tarsal bones, and these would be the metatarsals, and these are all the phalanges.
Okay, I just wanted to make sure, because I know that he said, Dr. Muffley said that those are like high yield for.
Yeah. So that's why I said like calcaneus heel, talus, tibia, and then you have your navicular more medial and your cuboid more lateral, and then your cuneiforms.
All right, thank you.
Yeah, gotcha. Okay.
Justin, to add to that, did he put the subtalar joint in here anywhere, like named as something else, or did he just skip that?
Yeah, I think he skipped it. I don't think he talked about it.
Okay, I was just making sure.
No, he doesn't talk. He didn't talk about the ligaments too much, so I wouldn't. I mean, I don't know, because Muffley didn't teach this lecture last year, as I said, but he did seem to glimpse over it during lecture, which is why I'm not going to put too much focus on the ligaments. Because there are just a lot of ligaments in the foot, like so, and a lot of them do say where they go, so that helps.
All right, cool. Thanks, buddy.
Yeah. Okay, and then what is the proximal attachment for all of these? What do you mean by that, Cameron? Not too sure.
Sorry, that was earlier from the flexors and extensors of the foot.
Oh, flexors. Oh, like these?
Yeah. Mm-hmm.
Oh, I mean, most of the proximal attachment is going to be on the tibia, and it just depends on the distal. Like it depends on which muscle you're talking about, though. A lot of them are going to be. Okay. So if you see in the earlier slides, like I've shown them like with the cartoon images, so that should be able to help like with the proximal attachments. You won't need to know like exactly where they're attached. I would just know like roughly where they go.
Okay, thank you.
Yeah, of course. Okay, and then, yep, so just lateral collateral ligaments, just, I don't know. Just you can see how many ligaments there are in the foot, just a lot of them. He doesn't talk about them too much. Here's your medial collateral ligament. Yeah, I mean, going from like your tibia to like more so like your talus / calcaneus. Okay, yeah, I mean, I'm not sure. I don't think he's going to test on it, but I don't want to say he's not going to test on it and then he puts on the exam. But I would definitely save ligaments to the last part of your studies. I would definitely know the leg muscles for the highest of yields in regards to what you need to learn first. And if you have time, just glance over the ligaments just for a little bit. But he did seem like he was going through the ligaments pretty quickly. Yeah, so nothing too much to talk about here. Just know this is the same thing in the ankle, or same thing in the foot, in the hand. You have like the metatarsal phalangeal joints, phalangeal or interphalangeal joints here, and then distal phalangeal joints here. It's the same thing in the foot as you have in the hand. Okay, so you have your ankle and foot. We're almost done. So you have your keystone. Just note that your talus is going to be the keystone to the arch of your ankle, right? So the arch of your ankle, your talus is going to be the keystone. So I noted that here. And then just note that your flexor hallucis longus, as well as your peroneus longus, also known as your fibular longus or fibularis longus, is going to help support the arch. So he points that out right here. You have your tendon of flexor hallucis longus, as well as your peroneus longus, just helping you give the arch in your foot. So he talked about it a little bit, so I put a little note right here just to help you remember that the flexor hallucis longus, as well as the peroneus longus, help give you that arch in your foot. Right? Okay, let's skip through that. And again, here's the arterial supplies. We've talked about these a lot. And again, here's the slides. So I won't go over them again, but I inputted the slides again after this just to help you reiterate which branches are coming off which, like anterior tibial artery, posterior tibial artery, as well as the posterior tibial artery turning into the medial and lateral plantar arteries. So I inputted these slides that I put in the beginning as well over here to give you like a little review, easier way to digest where these arteries are branching to and where they are going. So again, so here's our dorsalis pedis artery. Question? Oh, okay.
Yeah. You said the flexor hallucis longus and the perineal longus are the ones that support the arch?
Yes.
Okay, cool. Thank you.
Yep. Gotcha. And then you have your dorsalis pedis artery, right? So, yeah, I mean, it says it. I was going to ask, but it comes from the anterior tibial artery, right? So your anterior tibial artery turns into your dorsalis pedis artery, right? So you can see it right here. This is your dorsalis pedis. And then you have your medial and lateral plantar arteries, which are located right here. This would be the medial, and this would be the lateral plantar arteries. And those are going to be coming from the posterior tibial artery, right? So again, you see your posterior tibial artery turning into your medial and lateral plantar arteries. Right here it's the same thing, posterior tibial artery turning into your medial and lateral plantar arteries, right? So medial and lateral. Right, so if you use the images for the cartoon, they should be able to help in regards to recognizing them. Lumbosacral plexus, again, not going to talk about that. Nothing too high yield here. No, we've talked about most of these. He said not to know this, so I'm going to skip this. Yeah, he said not to know any of the cutaneous innervation of the foot, so I would just not look at it. So yeah, another slide that you don't need to worry about. So here are the nerves. Again, I put the slide in there again to help you review before he talked about the nerves again, because he brings the nerves back again in some cadaveric images towards the end of the PowerPoint, which is why I put the slide in here again to remind you that the tibial nerve gives up the medial and then as well as the lateral plantar nerve. You can see here, tibial nerve giving off the medial as well as the lateral plantar nerve. And then you have your common fibular nerve giving off your superficial as well as your deep fibular nerve, right? And again, so here it is. Oh, yeah. So I enlarged a lot of the images that he had because with my eyesight, like I definitely can't see that. So I enlarged it. I'm wearing contacts, that's why. Yeah, but yeah. So superficial perineal nerve. So this is going to be right here, this little superficial nerve right here. So you can see it's going to be supplying the lateral leg, right? It's going to be the lateral side of the leg. It's pretty superficial, right? You can tell. And again, remember, perineal equals fibular, so this is going to be your superficial perineal nerve. This right here is going to be your deep perineal nerve right here. This is your deep perineal nerve, going to be supplying the anterior compartment muscles. Does anybody remember what this is? This one right here.
Is there dorsalis pedis?
Yeah, this is your dorsalis pedis artery. Yep. Yeah, right on. Yep. This is your dorsalis pedis artery, and this is going to be a deep fibular nerve. So yeah, you'll be able to, the more you look at these cadaveric images, you'll be able to see which one looks like arteries. I mean, the arteries look more so like pink. The nerves are going to look like white / like elasticy, basically. So yeah, that would be your deep perineal nerve, and as well as your dorsalis pedis artery. And again, this is going to be your tibial nerve. So you can see like it's kind of like white, like stretchy. That's like how the nerves look, right? So this is your tibial nerve. So this is going to be your tibial nerve. Does anybody know what this is? This right here. If you had to guess, what would you say? Yeah. Yep. It would be your common fibular nerve, right? So this would be your common fibular nerve. Over here, you have your lateral and medial plantar nerves. So you have your lateral as well as medial plantar nerves as he indicated in this image. So this would be your medial right here. This is your medial plantar nerve, this one right here. So again, you can see like this is like it's like white / stretchy. So that's how you can tell that this is the nerve, right? This would be the medial plantar nerve. Very hard to see the lateral plantar nerve, but it's like this one right here, right? So what would these be? This one and that one. So this one, and then that one. Right, so since this is the medial plantar nerve, it's easier to see over here. Since this is the medial plantar nerve, which one would this one be? So what would this be?
Lateral nerve arteries.
Yes, yeah. So this would be the medial plantar artery, right? So medial plantar nerve, medial plantar artery. lateral plantar artery, and then lateral plantar nerve, which is like right here, right? So those are going to be where they are in regards to the images. And again, I put the arteries. Here's the breakup of the arteries. Remember, your posterior tibial artery gives off your medial and lateral plantar arteries. So here's your posterior tibial artery giving off your medial and lateral plantar arteries, right? So posterior tibial to medial and lateral plantar arteries, right? So yeah, I put that because he talks about arteries again. So we have our posterior tibial artery giving off our medial and lateral plantar arteries, right? So this would be medial. Yeah, this would be medial and lateral plantar arteries, and then our posterior tibial artery coming down. This would be your dorsalis pedis artery, right? This one right here, branching down from or an extension, of the anterior tibial artery, right? And then these are just the cutaneous innervations. I don't think he said to know much of this. I mean, we talked about the thigh, the cutaneous innervations of the thigh already, so I would note those, but the leg and foot, I don't think are too much high yield. Okay, and then
does it matter if it's great or small saphenous?
Which one?
Just when he says saphenous, because I know femoral, technically the small goes to popliteal, but that goes to femoral, so.
Oh, so for nerves, it's only a saphenous nerve. You don't have like a great and left. Yeah, so for veins, it would be great and small, or yeah, smaller and greater saphenous nerve. Vein. Yeah, so saphenous nerve is only going to be saphenous nerve. There's no like greater or lesser. While for the vein, it's going to be the great saphenous vein and like the lesser / smaller saphenous vein. That makes sense?
Yeah.
Yeah. Okay. Okay, and then so ankle and foot. So again, we've talked about these. Remember, like every so you have an extensor hallucis longus, which goes from your leg all the way to your foot. You have an extensor hallucis brevis, which is just the one that it does the same exact thing, but it's only located in the foot. Same thing with extensor digitorum brevis. You have an extensor digitorum longus, which we talked about, going from the leg all the way to the foot. And you also have an extensor digitorum brevis, which is just located in the foot. And you also have dorsal interossei, which are dabs. Again, this is the same image he talked about. So again, remember, you have an extensor digitorum longus, so coming from the leg, going all the way to the toes 2 through 5. You have an extensor digitorum brevis, which is just only located in the foot. Then you have an extensor hallucis longus, which is located in the leg, going all the way to the toe. And you have extensor hallucis brevis, just doing the same thing, but only in the foot. Right? So your plantar aponeurosis is just basically almost like the same thing as your like your palmaris longus, like the where it attaches to the palmar aponeurosis. It's kind of like that, but in the foot. I don't know how high yield the layers are. He doesn't seem like he wants to emphasize knowing like which ones are in which layers. So he didn't seem to care too much. He just wanted you to know which muscles are in which, basically, or like which muscles are. So for example, if it's an intrinsic foot muscle, you need to know that it's an intrinsic foot muscle, meaning it's only located inside the foot, right? So for example, we need to know that the abductor hallucis is only located in the foot, right? It doesn't come from the leg. It's only located in the foot, which is also known as an intrinsic muscle, right? So that would be an intrinsic muscle. I'm not going to go too deep into the layers. He didn't seem like he wanted to focus onto it. So these are just going to be the layers in regards to that. He did talk about, I just put like a little note here just in case, that the lumbricals run from the tendons to the bones. And again, remember, like in the hand, we talked about the lumbricals going to the flexor digitorum profundus. So in the hand, the lumbricals go to the flexor digitorum profundus, but in the foot, the lumbricals go into the flexor digitorum longus, right? So he said it in class, so I just put a little note on it. He didn't talk too much about which ones are going to be part of which layer, right? So, and this is your third layer. So I mean, I would put this as your lowest yield. Extrinsic would be flexor digitorum longus. Yeah, so your flexor digitorum longus would be an extrinsic because it comes from the leg and goes into the foot. But your your flexor digitorum brevis is only intrinsic because it's only located inside of your foot. So yes. So yeah, I would look at the layers as like a last thing, basically. But I mean, obviously, I don't know what he's going to test on, but he did seem to brush over it, right? And this is your dabs. So here are going to be the intrinsic. Most of these are going to be the intrinsic muscles. So again, I put slides after this, so you'll see like I enlarged a lot of these slides, or I grabbed a lot of these muscles, and I put cartoon images next to them. just in case he wanted you to identify any of the intrinsic muscles in the foot. I put them on the slides afterwards just to help you study. So for example, like here, like he put all the 4 muscles here for the flexors of the toes that are mostly intrinsic. And I just divided them up into like their own slides. So for example, this would be the interosseous muscles. And if you wanted to see what they look like, they would be like this, located on the foot. So just to give you like a general overview of like what intrinsic muscles would be. So a lot of these slides that are coming up next are just going to be on the intrinsic muscles of the foot. He just wants you to know that, like, you just need to know that these muscles are in the foot. That's what he specifically said. So that's what I'm going to go off of, is that just know that these muscles are located in the foot, and like, I guess what they look like as well, because he did put cadaveric images. So that's why I went out of my way to get you guys like actual cartoon images as well. Oh, somebody's mic's on. Oh, yeah. So that's why I got you all like cartoon images of it. So it's like the interosseous muscles. This would be the flexor digitorum brevis. So like you can see, you can kind of like match the muscle if you wanted to. So this would be the flexor digitorum brevis. You can match it exactly with the muscle that's shown right here, flexor digitorum brevis, right? So I put the cartoon image in order to help you match the muscles in order to see like if you wanted to know what they did. Same thing. This one is actually a little bit more higher yield because this is flexor digitorum longus. Remember, that's the one that's extrinsic. That's the one that's coming from the leg. So this one's a little bit more higher yield. The reason why you can tell that this is the flexor digitorum longus is because you can see that it's passing and going up into the leg, right? If it's going up into the leg, it's an extrinsic muscle. So this would be the flexor digitorum longus tendon, right? This one right here. What tendon? Does anybody know what this tendon would be? This one? If this is the flexor digitorum longus tendon, which tendon would this be? It's extrinsic, right? So it's coming all the way up. Yep, yeah, it would be hallucis. Yep, it would be flexor hallucis longus, right? So it would be coming all the way extrinsically and coming down all the way into the toe, right? So it would be the flexor hallucis longus. Yep, because this one would be the flexor digitorum longus taking all the other toes, right? So if you see something that's going all the way to the leg, assume it's an extrinsic, so it's more so the higher yield. And you can see this is your flexor digitorum longus coming down and supplying the toes 2 through 5, right? Except for the thumb. And here are your lumbricals. I also pointed out the quadratus plantae, which is going to be located right here. And again, you can mix and match basically the lumbricals here with the lumbricals there, right? So a lot of these slides I put here are just for your studies, basically to make the studies a little bit easier because there are a lot of muscles, but I wanted you to kind of just like glance over these slides in order just to know what intrinsic muscles are, where they're kind of like, I guess, roughly located. And if he does put a picture on it on the exam, you have seen it and you know how to like, basically like put it together basically. So again, same thing with these muscles, the short muscles that act on the greater toe. Here they are, all 3 of these. I broke them up into their own slides, right? But again, use them for your study material. I'm not going to go too much in depth in them, but I basically made these slides for studies. So for example, this is your flexor hallucis brevis. It's only located in the foot. Here's your mix and match basically. It kind of has like 2 heads, which is why he points at 2 heads. So you can see flexor hallucis brevis right here, as well as the second head of flexor hallucis brevis right here. You can see it kind of looks like this right here, right? That's your flexor hallucis brevis, just flexing your big toe, only located in your foot. So that would be that. This would be the adductor hallucis oblique and transverse head. So again, this would be the oblique head. I put an arrow right here, and this would be your transverse head, right? So same thing here. Here's your oblique head, and then here's your transverse head, just to give you a general overview of where these are located. Just in case he puts them. And then here's your abductor hallucis, right? So abductor hallucis, you can see would be located right here. I put a little star right here. And this would be your abductor hallucis right here. Right, so they match perfectly with the cartoon images, so you shouldn't have too much of a worry in regards to what they're supposed to look like in regards to what they actually look like in a cadaver, right? And lastly, just the short muscles acting on the 5th toe. Flexor digiti minimi brevis and abductor digiti minimi again. Here are going to be the corresponding muscles. Same thing here, used for your studies, just in case he puts an image on it. But again, he didn't put too much high yield on the intrinsic muscles. But again, he did have cadaveric images on there, so I didn't want him to draw a cadaveric image of an intrinsic muscle and then expect you to know exactly what it was. So I just put corresponding images to it to help you, just in case you wanted to look over those. And again, these are plantar nerves. You have the medial and lateral plantar nerves. So again, we talked about this. This is going to be, does anybody remember where the medial and lateral plantar nerves come off of? like which nerve branches off into the medial as well as the lateral plantar nerves?
Tibial nerve?
Yeah, tibial nerve, yes. Okay. So tibial nerve is going to give both of those. So here's our medial right here. Here's our medial, and then here's our lateral, right? So medial plantar nerve right there. And then this is going to be our lateral plantar nerve. That would be your medial as well as lateral plantar nerve. Okay. And again, here's the cutaneous innervation of the foot. I mean, he didn't put it too high yield, but I did put these little notes in order to help you study. You have your saphenous nerve, which comes from your femoral nerve, and your sural nerve, which comes from your tibia, as well as your common fibular nerve. And this is going to take like the lateral side, and this would take kind of like the anterior lateral side. But yeah, not too high yield on that. We talked about these pictures already. I've enlarged them for you all on the previous slides for the superficial perineal nerve, as well as the deep perineal nerve. And again, does everybody remember what this is? This one right here.
Dorsalis pedis.
Yes, dorsalis pedis, yes. Okay, and then we're almost done. I know this lecture was long, but it's the only lecture we're going over, so don't worry, I don't have anything after this. Again, this is just the foot movements. And again, just know that you can plantar flex more than you dorsiflex. You can plantar flex more than you dorsiflex just because of the shape of the talus, right? So you can plantar flex more than you can actually dorsiflex, right? Which makes sense, right? You can get in your tippy toes more than you can just lift your toes up, right? Okay, ankle injury, just note that the most common ankle injury is going to be forced inversion, which is just like this. This would be forced inversion. That would be the most common ankle injury. And again, you have strain versus sprain. Strain is just stretched but not torn. Sprain is actually torn, right? And again, here, he didn't talk too much about this. Just know that pes planus means flat arch. That's what I always know, is that pes planus means flat arch. And then over here, that pes cavus means high arch, right? So that's why I put a little star there. And then that's it, yeah. So very long, but I hope that lecture was going to help you guys get a general overview of like the leg muscles, and I'll be posting that literally right after this, so don't worry, I'll be able to use that for your studies. Anybody have any questions or any concerns, anything like that? I'm still answering emails, by the way, too.
So I got one. I only got an email from Dr. Blank saying classes are going remote Monday. Are we planning on doing all remote classes on exam days? I don't know if anyone sent something out yet, but I know they were deciding.
Oh, I don't know. I had no idea classes were going remote. I would hit up Rose, like I would send Rose an email in regards to what's going to happen for that.
Justin, quick question. Is there like a landmark that you suggest us looking for the medial and lateral plantar arteries and the medial and lateral plantar nerves?
A landmark. So
like on the cadaver images? Sorry.
Yeah, no, you're good. Let me see.
A lot of them just look so zoomed in to a point where it's like I can't really tell which one's going medial versus lateral. It looks more anterior and posterior to me than anything.
Yeah. So, do you see my screen right now? You see the screen, eh?
Yeah, we see it.
Oh, okay. So no, you're good. So, for example, like if you were supposed to image like this, you would know that this is medial and this was lateral because this is going towards like the big toe side, right? And this is going towards like the other toes. Same thing over here. So like, I know it's hard to see, but this would be like, for example, the right foot, right? So since this is going to be the right foot, you can see that the medial plantar nerve is going towards like the toe side, right? So going towards this side, and the lateral is basically going towards the back side, the lateral side. I guess the easy way to see this is that, is that kind of like the medial, like, I feel like the medial plantar nerve is going to be, I don't know. I feel like the more you look at it, you'll see that this is going towards the toe side because it's going to be like kind of like going towards the bottom of the foot, but going more towards the medial. And like the lateral plantar nerve is kind of like ditching, going towards the lateral side. So you can see how it like kind of like branches away. Like when it branches away this way, that's going to be the lateral plantar nerve. But the one that stays kind of like continuous is most likely going to be the medial plantar nerve. I know it's kind of hard, but the more you look at the images, you'll be able to understand. So I hope that helps a little bit.
Yeah, this one actually. It was on 59 in his slides. It's probably back like 10 more is where it's like really zoomed in. And he has a couple of those throughout his PowerPoint that is basically the same image that's like really close up and you can't really tell. Do you think he would just put this image up instead?
I think so. I think this one's a little bit more clear. So, and he did say that he was going to put more clear images, and I think this is going to be the most clear image in regard to the medial and lateral.
Okay, and maybe we could use that. Is that the tibialis posterior tendon, and maybe that could help us kind of orient ourselves as well? Is that what that is? The tibialis posterior tendon?
Which one? This one?
Next. Yeah.
Yeah, that can help you orient yourself. Yeah, I guess that can help you orient yourself.
Because the medial one is closer to that.
Mm-hmm. Yeah, you can use that as a landmark.
Okay. Mm-hmm. All right, thank you.
Yeah, of course. Okay.
It does seem like Auckland images favor the right limbs.
Yeah. Yeah, it does seem like they do favor the right limbs, yeah.
My question, Justin, was the pectineus muscle from last time. He has it on the medial and anterior thigh sections because it's innervated by the femoral and obturator nerve, but he has superior rami and body as the origin of the pubis.
For the pectineus?
Yeah, for the pectineus, but it's just superior rami, right?
Yeah, it's more so just superior rami. Yeah.
Okay. Make sure there's no two parts or I'm missing it's attached to both. It's more superior. Okay.
Yeah. Okay, and then I can I can stay after. So yeah, I can stay now, and then you guys could just ask me any questions you have in regards. Actually, if you don't have any questions for the practice exam, ask now, and then when you're done, I'll just let people ask the questions for the practice exam, and I'll pull the practice exam up for people who haven't taken it. You can head out if you want. But the people who have can ask me questions in regards to the practice exam. So if you have any questions not regarding the practice exam, ask now, and if you don't, then we'll look over the practice exam.
Hey Justin, so I was wondering about movements for the upper limb. I've seen some places that like forearm flexion versus like elbow flexion. Are those the same? And then like shoulder flexion versus arm flexion, are those the same?
Yeah, so with forearm, so you said forearm flexion and which one?
Forearm and elbow.
Yeah. It's kind of like the same thing, yeah. Yeah, forearm flexion, and then arm flexion at shoulder flexion, yeah.
Hey Justin, I actually do have a question.
Yep.
For tonight at 5 p.m., I know you're going to go over this PowerPoint slide again, but are you also going to stay over a little bit to go over the practice exam? I think I'll be able to finish it by then, so you can go over it with you.
Yeah, I'll go over it again then after the 5 p.m. If that's what helps you all, yeah, I'll stay. Mm-hmm.
Awesome, thank you.
Yeah.
Hey, Justin.
Yep.
I have a question about the lumbosacral plexus.
Mm-hmm.
He said that we only needed to know the peripheral nerves. Does he mean like just know what nerves come off the lumbosacral plexus,
yes,
or know them like relative to each other, like which one's superior to each other?
I mean, I would still note just the general relations, like how we talked about the genitofemoral is superior to the psoas major, and then you have the femoral nerve is lateral and the obturator nerve is medial. I would note that, but other than that, I would just note the peripheral nerves, which ones come off of the lumbosacral plexus.
Okay, thank you.
Yep. Any more questions before I take questions for the practice exam?
Real quick, man, what's high yield off the very first PowerPoint? Just like planes, movements?
Yeah, so it's probably just like, it's just some planes, some movements. Honestly, nothing very high yield. Other than the questions I put, like the first 5 questions, I would say or the first 3 questions I put on the practice exam would be probably the highest yield in regards to the first PowerPoint.
All right, cool. All right, man. Thanks for everything, buddy. We really appreciate it.
Of course, yeah. Yeah, no problem. My bad, y'all. I knew this one took a long time, but I had to make sure we got this lecture down packed.
No, it was good. Thanks, man.
Okay, I got you. When distinguishing between, let's say, extensor digitorum longus and extensor digitorum brevis, he'd have to give us the cadaveric image of the leg in order for us to distinguish between the two, correct? Or is there a way to distinguish between them with a zoomed-in image on the foot? No, he's probably just going to give you a picture of one that's just only in the foot, right? So if it's only in the foot, he's most likely, he could be talking about the extensor digitorum brevis, but he'll most likely talk about the extensor digitorum longus in relation to coming from the leg as well as the foot. But yeah, he'll most likely do that in regards to a cadaveric image. Will he have the same amount of questions per lecture? I would say most likely I think he would have the same amount of questions per lecture. He tries to keep it pretty even. Other than the intro, he'll probably have way less questions on the intro than he does on anything else. Okay. Do we need to know the content of the popliteal fossa? Well, I would know. Well, you do need to know the borders, and then the content. I would know them generally. They do have a lot of the like popliteal artery, popliteal fat. Like a lot of the things are like popliteal, and I would just note a few of the things that aren't. But other than that, that's what you need to know for the popliteal fossa.
What are the other things again? The is it sural?
Yeah, so it's sural nerve, as well as like one more, I think. But I think that's about it. Yeah. Do we have another mnemonic for the tarsal bones like you had basically? Oh yeah. So I didn't make a mnemonic for the tarsal bones because it didn't seem as high yield, which is why I did put like, okay, just know that navicular is medial, cuboid is lateral, calcaneus is your heel, talus, T for attaching to the tibia, and then you have your cuneiforms as well, right? So I would just note them just in case he does talk about the tarsal bones, but I did highlight a few of those on my lecture. But yeah, no, I didn't get a mnemonic for that. Okay. All right. So if there's not any more questions, feel free to ask me any questions regarding the practice exam, and then I'll pull it up, and then we'll discuss it.
Hey, I haven't done it, but I'm looking where it's at on Canvas. It's not the practice quiz, right?
No, it's under modules. My modules are. So if you go to modules, where you download my lectures, it should be right there.
In the lectures category?
Yeah, so like where you download the PowerPoints that I post, it should be right there.
All right.
Do you see it?
My computer's going real slow right now. I got like 100 things going.
No, you're good. So okay, hold on.
Yeah, I see it. Thanks, man.
Gotcha. Okay, so you said after reviewing the practice exam, I noticed that number 7's answer may be incorrect. Mind touching on that? Okay, let's see. All right, I'm gonna. Let's see. All right, so the sacrotuberous ligament is going to be so the sacrotuberous ligament is posterior to the sacrospinous ligament. So I wish I can pull up an image for you right now. Hold on. Let's see. Hold on. All right. 1 second. Can you see my screen? Okay. Well, I hope you can. But yeah, so this is going to be the sacrotuberous ligament, right? So you can see this ginormous ligament right here is actually posterior to the sacrospinous ligament, right? So if I remove the sacrotuberous ligament, you will be able to see the sacrospinous ligament going from the ischial spine to the sacrum, right? So this is how the sacrotuberous ligament is going to be posterior to the sacrospinous ligament. Does that help?
Justin, is this view anterior or posterior?
This is posterior.
Okay.
Gotcha. Okay. All right, and then next one. So you said for number 20 on the practice exam, the picture is showing the teres major, correct? Which is innervated by the lower subscapular nerve. Yep. And then I didn't think that shared an innervation with anything because the rotator cuff muscles are innervated by the suprascapular nerve, except for teres minor, which is innervated by the axillary nerve. Okay, so let me pull up the PowerPoint. Okay, so number 20, right? So okay, so here's your teres major. Yeah, so it actually shares an innervation with the subscapularis because the subscapularis is going to be innervated by the lower subscapular nerve as well as the upper subscapular nerve, right? So since the teres major gets the lower subscapular nerve, your subscapularis also gets your lower subscapular nerve as well as your upper subscapular nerve. So that's how they share an innervation, right? Because the teres minor is going to get axillary nerve as well as the deltoid muscle will get axillary nerve. Does that make sense, Kalina? Yeah. Okay. And then for number 24. Okay, so number 24. So you have the brachioradialis shares an innervation with which other muscle? So what are the other innervations of the rotator cuff muscles? Yeah, so you have supraspinatus and infraspinatus is going to be from suprascapular nerve, right? Then you have what's the last? So you have a teres minor is going to be from axillary nerve, and then subscapularis is going to be upper and lower subscapular nerve. And then we talked about teres major, which is not a rotator cuff muscle, which is going to be supplied by lower subscapular nerve. Right. And then for 24, so the brachioradialis first and foremost is going to be innervated by the radial nerve. So if you remember, the radial nerve is taking the posterior compartment of the arm as well as the posterior compartment of the forearm, right? So what's going to happen is that anything that's going to be on the posterior compartment of the arm and forearm is going to be innervated by the same innervation of the brachioradialis. Brachialis is on the anterior side, so that's known. Flexor carpi radialis is on the anterior side, that's known. Extensor digitorum longus, that's actually in the leg. So extensor digitorum longus, remember, that's actually going to be in the leg, right? And that's going to be extending the toes of 2 to 5, right? So this is going to be in the leg, so not radial nerve. And then abductor pollicis longus is going to be part of your snuff box. Remember, it's one of the ones in your snuff box, and that's on your posterior side, so that's going to be innervated by radial nerve. Yeah, I tricked you because that's a leg muscle. Yeah, so I put that in there. Yeah, because there was a leg muscle, and I didn't want you all to get confused on the exam, just in case you put it. Okay. 15 and 11. Okay. 15. Okay. So this is going to be the pectoralis major, right? So the pectoralis major is going to help with adduction. So you can imagine basically pulling your arm back to your body, right? Because if you contract this muscle, it's going to be pulling the arm back to the body. So it helps with adduction, right? It's also going to be helping with medial rotation as well, because it's going to help turn the humerus towards the inside, basically. So turn your humerus inside, right? It's not going to help with abduction. So if you lift your arm up, basically, remember, like that's like abduction. That's going to be mostly your deltoid and your rotator cuff muscles, right? That's not going to be your pectoralis major. It doesn't help with any sort of abduction. Yeah, so that's going to be that one. Okay, and then which one else? 11, right? 11 as well. Okay, so for 11, we have, so if you damage the posterior core of the brachial plexus, the muscle innervated by the white arrow would be affected. False, yeah. So if you know that, yeah, this is a little tricky question too, but the long thoracic nerve is going to supply the serratus anterior, right? So if we pull up the see brachial plexus, I'll show you.
Justin, for this one, I was thinking, so there's the posterior cord, then you go all the way back to the root, and then I watched the brachial plexus video, and it said that the lateral thoracic gets some contribution from C7. So then I was thinking, well, if you mess up the posterior cord, do you end up messing up the whole thing all the way up to C7? And then I thought, well, then maybe you'll mess up the lateral thoracic too. That's what I was thinking. But maybe it's just asking about just the posterior cord or something.
Yeah, like I'll show you. Like I pulled it up on this image. Okay. You can see my screen, right?
I just see the test.
Oh, you don't see the. Oh.
I think it'll come up. My Teams is kind of slow today, so.
Oh no, you're good. Yeah, just let me know where you can see. Wait a second. Okay, so.
Yeah, I see it now.
Okay, so, what's gonna happen? You see, this is the long thoracic nerve, right? So it's coming off from like C5, C6, and C7. So if you, for example, just cut the posterior cord, right? Nothing's gonna happen to this long thoracic nerve because it's getting supply from something that's much later on, or much earlier on, right? So anything that's distal to the posterior cord is going to be affected.
Oh, distal. Okay.
Does that make sense?
Yeah.
Yeah. So nothing before is going to be affected because you're cutting here. So anything before that's fine, right? But anything after that's going to be damaged.
And then in that picture, what are those two nerves? What is it? I don't remember seeing that in any of the cadaver pictures.
Oh, like the medial cutaneous and medial cutaneous deformity.
Like in the test, there was the picture of the serratus anterior, and then to the left of that, two nerves, I think. Like in the test question.
Oh, in the test questions. Hold on, let me see. Which question are you asking?
11.
11. Okay, so you said you've never seen these nerves. You're asking about the nerves?
Yeah, maybe they were there. I just don't remember, but.
Yeah, they're on the slides. Yeah.
Oh. And.
Yeah,
and what are they?
Yeah, so that would be the long thoracic nerve, the one that's supplying the serratus anterior.
Oh, like what that pointer thing is?
Yeah, what that pointer thing is pointing at, yes.
Oh, okay. All right. Thank you.
Yeah, I got you. No problem. Okay, can you go over 39? Oh, yeah, so yeah, Dr. Muffler, yeah, he looked through the questions, yeah. Yeah, he thinks all the questions we write are pretty similar in regards to the test. Okay, so can you go to 39 and 44? Let me share my screen really quick. Okay. So 39. Okay. So yeah, this is going to be the obturator externus. What was your specific question, Carlos? For 39.
Hey Justin, it's Carlos. I guess I was just having trouble I don't know, differentiating with the muscles. I don't know. I just find that area really confusing because I know that there's so many muscles there. So,
yeah. No, I get you. It does get really confusing because it kind of like, I guess I can see it looking like the piriformis and like some other muscles, but for in order to help you, I guess, remember that is that this is the obturator like foramen. If I was to remove this muscle, like you'd have that little hole, which is the obturator foramen. Anything that covers the obturator foramen on the outside, that's the obturator externus. If it covers it on the inside, that's going to be the obturator internus.
Okay.
And then the piriformis is actually going to be going like right through the greater sciatic foramen. This is the obturator foramen. You can't see the greater sciatic foramen because it's like on the posterior, kind of like posterior side, and it's not a good angle in this image.
Okay.
So does that help a little bit in regards to? I know they look like all the same, kind of confusing, but.
Yeah, that's the one area I was having a bit of trouble with, but I'm gonna go ahead and take a look at those Eklund tapes.
Okay, for sure.
To help me out. But yeah, thank you.
Okay, for sure.
And yeah, if you could just go over the anatomy for 44, if you don't mind, please.
Yeah, of course. Yeah, 44.
I had trouble even because I know I could I believe that's the inguinal ligament, is it?
Yes.
Okay, so I knew that, but I don't know. They all seem the same to me.
No, I know. Yeah. So it's tough. I know, especially when you're looking at it for the first time. So if you know that this is the inguinal ligament, then you know that this is going to be the external iliac turning into the femoral artery, right? So when you pass the inguinal ligament, that's when like the external iliac turns into the femoral artery. And then the first two branches off the femoral artery are going to be this one and this one, right? Yeah. So this would be superficial circumflex iliac right here, and this would be external pudendo artery. You could tell this is pudendo goes to like the perineal area, so like the genital area. So it's going towards like the inside of your genital area, right? This would be going towards like the lateral side of your body, towards the lateral side of your leg, right? So this would be the external pudendo artery. But if you keep going down the femoral artery, you can see this little thing right here. That's actually the deep femoral artery, which is going to go and supply the posterior compartment of the thigh. So this little thing is going to be the deep femoral artery.
All right, thanks. That helped a lot.
Yeah, okay, for sure. Yeah, the acronym tapes really do help. So if you want to do watch those do help a lot in order to recognize where these areas are.
Could you go over the joints again? Number 3 is a plain joint. I knew like the ball and socket. I knew like the I know some, but I haven't really gone over the first PowerPoint that much, just because I know like there's so much more important yet.
Yeah.
So if you could please just go over that, I'd appreciate it.
Yeah, so the acromioclavicular joint, that's basically going from your acromion to your clavicle. So that's just a plain joint. So that's very like little movement. Your atlantoaxial joint, that's your AA. So like your pivot joint. So it turns from like AA like side to side. So that's your atlantoaxial joint. So since it turns from side to side, that's going to be a pivot joint, right? So it helps you pivot your head side to side. Your metacarpal phalangeal joint, that's going to be your condyloid joint, right? That's going to be from your metacarpals, like here, like in your palm, to your phalanges, which would be your fingers, right? So that'll be like the joints here, right? These joints. It's basically your knuckles, right? So your knuckles are going to be your condyloid joints. They help with like a lot of movement, but they don't have as much movement as your thumb, right? So your thumb is going to be your carpometacarpal joint, which is a saddle joint, which helps you like move in all these types of angles, right? Does that help a little bit?
Yeah, man. Thank you. I appreciate
Yeah, of course.
Can you just explain the thought process on 46? I think I'm just blanking.
No, yeah, you're good. All right, let's see. 46. All right, so the sciatic nerve is the largest nerve in the body, originating from L4 to S3 off the lumbosacral plexus, going down the posterior side as it passes through the greater sciatic foramen, just inferior to the piriformis muscle. All other nerves will follow the same path as the sciatic nerve, going inferior to the piriformis muscle, except, okay, so we have to know that which nerves are going to be going under the piriformis muscle, and that's going to be almost every single nerve that goes out of the greater sciatic foramen is going under the piriformis muscle, except for the superior gluteal nerve, because what happens is that when it goes out of the greater sciatic foramen, the superior and inferior gluteal nerve go inferior and superior respectively in regards to the piriformis. So the superior gluteal nerve just comes over the piriformis, and then the inferior gluteal nerve is going to go under. And then everything else is just going to go under the piriformis, right? So think for superior gluteal nerve, think it's going to come out above the piriformis muscle. Does that help a little bit?
Yeah, thank you.
Okay, for sure. All right. Anybody else or any other questions?
For that question number 46, I was thinking along the lines, like I got that one wrong because I was thinking along the lines of like, which one didn't? I guess I just read it wrong. I was just thinking like pudendal just because I knew that like it went into both. Like I just read greater sciatic foramen and then just initially just my mind went there. So.
Yeah. No, I get that. Yeah, it does go inferior to the piriformis, but yeah, it does go back to the lesser sciatic foramen. Mm-hmm. But, yeah, of course.
And then for 36, you said if you pointed to the top, that would be the plexus?
Yes, if you pointed at the top, this would be the sacral. Yes, sacral plexus. Yes. Any other questions? Okay. Any other questions? Doesn't have to be on the practice exam. Anything else? Any last second questions before I let you all go? And good luck with your studies. I know you all got this. Exam's going to be tomorrow, so I will be posting this PowerPoint right after I hang up on this call to make sure that you guys are getting the information. So, yeah, feel free to let me know if you have any questions. All right. If not, thank you all for coming to the session. Good luck with your studies, and let me know if you need anything. And, yep, take it easy, all right?